think, yeah. Very good evening, good afternoon to you all. Today we start the first of the Quest series. It will be a monthly series from FOGSI, focusing on different and important practical issues in both gynecology and obstetrics. Today, the first Quest series will focus on a very enigmatic and very important topic, that is PCOS across the ages. And to cover this, we have an array of experts, faculty, and very senior members. And we have very senior stalwarts as guests of honor. So, without further delay, I would like to introduce Dr. Krishna Kumari Madam, who is the convener for this program. Professor Krishna Kumari, as you all know, is presently the HOD, Professor of Apollo Institute of Medical Sciences. She had been the president of our Obs-Gynae Society, presently national coordinator and national corresponding editor Jogi, with immense and vast experience of both teaching as well as OB-GYN practice. And she has a decade. She's our permanent scientific chair for OGSH as well as the FOGSI conferences, which we do from Hyderabad, both international and national. She has a lot of contributions to many textbooks and also faculty at various national and international programs. Over to you, Krishna ma'am, to start with the program.
Thank you so much, Kiran, for your kind introduction. And it is, I'm especially privileged, and it's a pleasure to be among all the stalwarts today and discussing about such an important topic. We have as one of the most, I think, known practical as well as clinically, we keep seeing so many cases, which it's been 100 years. I think it is in 1921 that first they described PCOS was described as the bearded women, you know. From then onwards, it's more than 100 years, and still we are finding it an enigma and trying to unravel the mystery behind it. And like Kiran said, we have really eminent speakers for that. And for that, the first session is on unraveling the mystery of PCOS. I invite Dr. Anita Singh and Dr. Kiran Chandana as chairpersons. Can I have the slide of Dr. Anita Singh? Yeah, we all know her, but as a formality, I would like to introduce her as the ex-professor of Patna Medical College. She has been the past president of FOGSI, vice president of FOGSI very recently, and she has been the chairperson of endocrinology committee 2014 to 16. Do we have some disturbance there?
Yes, we are having. It's not audible.
Audio, yeah, thank you. I think actually, ma'am, you don't need much introduction, but still continuing with your CV, you have been the chairperson of endocrinology committee and a member of the governing council ICOG, and you're a chief consultant to JP Hospital and Patna. Can somebody look into that noise that is coming?
Actually, it was from Anita madam's mic only. It is muted now. Yes.
Okay. Can I have the other chairperson, Dr. Kiran Chandana, CV, please? Yes. She's president of Faridabad Obstetrics and Gynecological Society, and she has been the member of FOGSI MTP committee. Her special interests are in adolescent health and contraception. She has always been an active member in FOGSI and for the Haryana Obstetrics and Gynecological Society, who has contributed to various journals with a work experience of 35 years, and she is also the director of Chandana Medical Center at Faridabad. I think we have two eminent chairpersons, and I request them to introduce the next speaker, the speaker. For the first speaker, Dr. Suvarna Khadilkar, whom we all again know, who is going to talk to us about understanding the disease of PCOS. Over to you, ma'am.
Okay, thank you, Dr. Krishna Kumari, for such elaborate introduction. Will somebody project the slide of Dr. Suvarna?
Yeah,
it's there. Dr. Suvarna Khadilkar, everybody from FOGSI knows about her, and she is at present Deputy Secretary General of FOGSI. That is her most recent introduction, I should say. And she has been there, hold various posts. And she was chairperson of endocrinology committee, and I'm very fond of her because I took charge of endocrinology committee as chairperson from Dr. Suvarna. So I always feel proud about it. So is the introduction slide there? Can somebody project it for me?
It is there, madam.
Madam, it is there, ma'am, projected.
Okay. At present, she is professor and head of obstetrics and gynae, consultant endocrinologist, and at Bombay Hospital, Institute of Medical Sciences. And as I have said, she is Deputy Secretary General of FOGSI at present. She is Secretary of Mumbai Obstetrics Gynae Society, current Secretary. She is Editor Emeritus, Journal of Obstetrics and Gynae of India from 2021 onwards. As she had been with FOGSI Journal for a long time, and she was treasurer just before she joined as Deputy Secretary General. She has been president of Indian Menopausal Society in 2017, and she is also president Association of Medical Women of India, Mumbai branch, 2011-12. She is editor of several books and more than 100, and she has also won several prizes and awards for those books, and she has delivered many orations, keynote address, and we all are quite aware of her academic capabilities and her HPs to deliver her talks. She is also a member of FIGO, Committee of Well Women Healthcare, current one, 2021 to 23. She is member of corresponding editorial board AOFOG, JOGR. She is also member FIGO, so I think member FIGO Working Women Group on Post Reproductive Health, and she is a recognized teacher not only in India but also in the University of South Wales, UK. So with this, I think I invite Dr. Suvarna to deliver your talk, which is most awaited by most of the delegates.
Thank you, Dr. Anita. I hope I am audible. Am I audible?
Yes, you are audible.
Yes.
Thank you, Dr. Anita.
Please unmute.
You are muted, Dr. Swan. Yeah.
I think I'm being muted again and again. I don't know what is the problem. Okay, I think I'll go ahead. So thank you so much, Dr. Anita, for kind introduction. And I, at the outset, I would really like to thank Dr. Shanta Kumari and the whole team, especially Dr. Kiranmai, who is leading, Dr. Krishna, and the whole team who's working on this program for last several days. And it is such a great thing to see our senior members like Dr. Chandravati, who's already joined. And really, I feel honored. Dr. Usha Sharma's name also I saw as a list of, guest of honor. And it's really wonderful to connect here. And, when she called me, she told me, you have to talk on something understanding of PCOS. I say, are you all right? Understanding of PCOS since 1731, it is going on. Has till today nobody has understood what is what. I think we are still struggling with what it is all about, from where to begin. Various theories are coming up. So allow me to share the screen so that I'll straight go on to. Can you see my
It's opening, ma'am.
Yeah, I had kept it open actually. Okay.
Slideshow.
Yeah, right.
Yes,
so I think this is something very difficult for everyone to understand this topic, but still it is so common that we are doing our best to understand it. And more than that, we want to make our girls, women comfortable after understanding, to give the right kind of treatment and to give them quality of life. I think this is something they have titled in various WhatsApp groups, and so you want me to understand a riddle which is wrapped in mystery, in an enigma. So the title itself says that it is such a difficult thing. So I will try and do justice. See, all of us know that Steen and Leventhal had published a case series in 1935, and since then it was called as Steen-Leventhal syndrome. But very few people know that it was first described by Valsinier et al. In 1721, and they had described this as young married peasant woman, moderately obese and infertile, with two larger than normal ovaries, so bumpy, shiny, and whitish like pigeon eggs. So this was described since many years. So I think we have to, and we are still not able to understand why it happens. Let us see how the understanding at what stage it is today. It is the leading cause of anovulatory infertility and hirsutism, and it's a matter of serious health concerns as well. So risk of developing PCOS is 40% if the sister is affected, 10% if the mother is affected, and it is supposed to be autosomal dominant transmission. About 20 to 33% of all reproductive age women will have polycystic ovaries. 5 to 10% of all of them will have polycystic ovarian syndrome. 87% of women with oligomenorrhea, 26% women with amenorrhea, 50% of them will present with infertility, 50% of them will also have recurrent miscarriages. So I'm just briefing this. I mean, know that the next talk is on diagnosis, but for our understanding, the PCOS has to have, we are universally following this Rotterdam criteria. Any two of the three must be present. So hyperandrogenism, either clinical or biochemical, and polycystic ovarian morphology and oligoovulation are the three criteria. But in adolescent girls, they have said that if you are looking at polycystic ovarian morphology, the volume of ovaries should be more than 12 cc's and not like 10 cc's which we see in adults. But it is not really essential to have and document this in young girls. But if at all you are looking at it, that was the diagnosis. These are the various diagnostic systems which you are going to see in the next lecture. I personally like this androgen excess definition and recommendations, where they say that hyperandrogenism and ovarian dysfunctions have to be there. At least one of each must be there to diagnose, and exclusion of other androgen excess and related disorders is a must. So let us see, these are the various diagnostic features. I'm going to skip these slides, but look at these four basic categories, the phenotypes that we have been described as per Rotterdam criteria. The last one is the non-classic, which is mild. And this is where the difference between the two classifications lies, where here the normoandrogenic women also are classified as PCOS, where the androgen levels are normal, but they say that these are a type of milder kind of PCOS. Now, why do they say it is the non-classic milder normoandrogenic PCOS? Because the key factor which leads to several metabolic dysfunctions and several, cascades and vicious cycles of pathophysiological features of PCOS, the key factor is hyperandrogenism. So hyperandrogenism is very essential factor which leads to several metabolic dysfunctions. Now we have metabolic pathogenesis of PCOS at various stages of life. So if you look at prenatal, postnatal, and adult type of PCOS, in prenatal phase you will find that in utero, if the mother has excess androgens in her blood, or if the fetus is exposed to excess androgen in utero, then these girls will develop PCOS. There are certain endocrine disruptors. There is babies who are faced with growth restriction, IUGR babies, they have a tendency to develop PCOS. And there is also AMH excess, and that is a common association with PCOS. In postnatal phase, after these girls who are predisposed or at higher risk of development, they have insulin resistance later on. They have developed obesity, and especially this obesity is secondary to environmental factor of overeating, excess eating, and these factors. and they face androgen excess, and there are certain endocrine disruptors which are responsible for this kind of postnatal development of PCOS. And in adult PCOS, so epigenetic factors and genetic factors are already there, and both together they develop what is in addition there is an interplay of environmental and genetic factors, and then in adult phase they have this PCOS. Now, what is the impact of androgen excess? So androgens will have effect on adipose tissue. It has effects on fat distribution. It alters the adipocyte size and differentiation, and the lipolysis and adipokine secretions. The liver, there is an independent factor that it may lead to non-alcoholic fatty liver disease. So there can be associated fatty infiltration. Muscles, there is a reduction in glucose uptake due to insulin resistance, and all this is because of androgen excess, and direct action on beta cell function through androgen receptor on the pancreas. So these are the various impact on, and on CNS also there is a direct action of androgens on the brain, which leads to hepatic insulin resistance and metabolic reproductive derangements associated with PCOS. So this rather explains that this is not limited to reproductive organs or health, but it is a multi-systemic impact of this PCOS and its androgen axis. So these are the various, what we just discussed, the adipose tissue, the metabolic impact via brain, then we have leptin mediated thermogenesis, then we have insulin sensitivity, liver, pancreas, skeletal muscles. So the hyperandrogenism has so much of effect. Now, if you see the etiological classification, if there are causes lying within the hypothalamo pituitary ovarian axis, if the fault lies in the lies in the HPO axis, it is what we normally see, and that is a classic or primary PCOS. But now we are having an emerging concept or more understanding that secondary PCOS will develop if there are certain causes other than defects in HPO axis. So any other causes, that thyroid malfunction, or there can be severe obesity, insulin resistance, all these adrenal abnormalities, so they all can contribute to development of polycystic ovaries and a syndrome which mimics the primary or classical PCOS. So let us see what is the vicious cycle of persistent anovulation. If there is a persistent chronic anovulation, which is most of the times, it is a result of genetic and environmental factor, which we just discussed. And this persistent chronic anovulation will lead to chronic deficiency of progesterone, which will lead to decreased hypothalamic opioid secretion, which further will lead to decreased inhibitory effect of opioid on GnRH secretion. There is increased pulsatile secretion of GnRH, and there is increased LH secretion, which brings about increased androgen secretion and decreased aromatase activity, which further precipitates chronic anovulation. So this cycle goes on and on and on. The patients don't ovulate, so there is a chronic anovulation. And genetic and environmental factors will also bring about, which is genetically determined. You know that diabetic mothers have diabetic children. So this insulin resistance will cause, and hyperinsulinism will lead to, there is a direct action on androgen secretion, and there is a decreased aromatase activity because of this insulin, and further there will be, so there is the first first vicious cycle of persistent chronic anovulation, and second vicious cycle of androgens, insulin, increase LH and androgen. So this is the second cycle, but that goes on and on. Therefore, unless you break this cycle with certain medication, this chronic persistent anovulatory status, hyperandrogenic status will go on. So this is the secondary cause of this PCOS. We have that editorial written in my this Jogi journal in July 2019. Those who are interested can go through that article, which describes in detail. These are the various causes of secondary PCOS. where obesity, thyroid, pituitary, adrenal, and neuroendocrine, drug-induced, there are certain drugs which can mimic entire PCOS-like syndrome. So before you exactly understand what is this PCOS, are you dealing with a primary PCOS or there is any associated other similar disorder which is causing secondary PCOS? So what are the metabolic dysfunctions that you see? Of course, hyperandrogenemia, we see visceral obesity, we have fatty liver, dyslipidemia, inflammatory cytokines, and there is a lot of oxidative stress, hemostatic dysfunction, endothelial dysfunction, atherosclerosis and hypertension, insulin resistance, hyperinsulinemia, impaired glucose tolerance test, diabetes mellitus, and last but not the least, cardiometabolic risk. And that is the reason why we are wanting to continuously control, prevent the various PCOS metabolic implications and effects. Now let us see the metabolic syndrome in adolescents and adults. The definitions are different. So these syndromes are, there are, as per this ATP, pediatric ATP3 diagnostic criteria, as you can see here, there are, blood glucose more than 100, HDLC less than 40, triglycerides more than 110, waist circumference. Always in adolescents, you take the percentile. So age and sex more than 90th percentile, and blood pressure also more than 90th percentile. If you find any, criteria, any 3 of the 5 criteria, then the patient, the girl or that young child is also at a higher metabolic syndrome. And PCOS, these are the 11% higher incidence of compared to age matched controls, and all these abnormalities are there. So co-occurrence of 3 or more of the following risk factors that we just enumerated for adults. There are certain developments later on, that definitions of Asians are for the waist circumference more than 80 instead of 88. And the fasting serum glucose has come down to 100 more, rather than 110. Otherwise, these are any 3 if you've come across in a patient, then she is suffering from what is metabolic syndrome. So these are WHO criteria for metabolic syndrome, and these are the little different than that. They have the major criteria, any 1, type 2 diabetes, this impaired glucose and all that, and any 2 of the following should be over and above this, and like any antihypertensive medication, then triglyceride levels, cholesterol, and BMI more than 30. So all these are the metabolic impacts of whatever biochemical changes that are happening in patients of PCOS. Now, PCOS goes through ages: adolescence, reproductive, and perimenopausal. So I came across a very nice article who really describes how PCOS, evolutes through from in utero to menopause. It's a fantastic concept. And if you see the in utero exposure to prenatal androgen is the cause which favors the visceral adiposity. In infancy, you will find that the daughters of women with PCOS have a greater follicular complement and mild metabolic abnormalities from infancy, and onset of hyperandrogenism in puberty is preceded by premature puberty. In reproductive years, if these women who are clinically or genetically predisposed or are, daughters of those hyperandrogenic women, so if they are exposed to environmental excess of high calorie diet, or they have the poor lifestyle factors, so they precipitate the PCOS, and in reproductive age group, they will face the PCOS. In menopausal age, however, all this right from reproductive age, there is a gradual decrease in the severity of cardinal features of PCOS. And at menopause, majority of women who had PCOS during their reproductive years will continue to manifest other cardiovascular risk factors. However, among age-matched controls, majority, we expect that these PCOS women will have higher cardiometabolic risk when they reach menopausal age. But the result has shown just the opposite, that the majority do not present an increased risk. The women beyond menopause, they match with each other with PCOS as well, because PCOS women have been, facing the higher cardiometabolic age for a longer period. But after the normal non-PCOS women also catch up with them. So what is the adolescence prevalence in India? The prevalence in India is 3.7% to 22.5%, with 9.13% to 36% prevalence in only adolescents. So imagine the magnitude of our young generation who is facing PCOS, and there is a wide variation in prevalence. It's bound to be there because there is heterogeneity of symptoms, diagnosis, and uniformity of the diagnostic parameters. So what is new in the understanding of PCOS? So this is very important. The genetic factor, it is hereditability is 79%. And this is WAS, which has identified 19 loci associated with PCOS. So these loci are located in close physical proximity to several potential candidate genes. Please let me know if my time is up. Okay. So including the insulin receptor, thyroid adenoma associated, the FSH receptor, and the other receptors. So 3 important genetic loci the PCOS gene is located. These are the prenatal factors which we have understood better now. So odds ratio for developing PCOS is higher for women with birth weight less than 2.5. So all IUGR girl babies or female babies are at higher risk of development. Low birth weight followed by excessive postnatal weight gain is the most important cause for developing PCOS later on at the adolescence and adulthood. Premature puberty and developed because of the excessive postnatal weight gain. Hyperandrogenic prenatal environment influences genes implicated in pathogenesis of PCOS we just described. So this prenatal androgenic says you must understand that if this, the mothers are naturally very apprehensive, or babies are small, underweight, less than 2.5 kg, they try to overfeed the baby. And then these babies, they catch up and they cross, they do not maintain their Z course of growth postnatally. So they gain lot of fat intake, and this fat is deposited, and the adiposity in the central obesity, it increases, and there is a mismatch between the prenatal adipogenesis and postnatal lipogenesis. Therefore, these are the IUGR girl babies who are very, very at higher risk of developing what is this all concept of smart escape. It is from central obesity, early adrenarche and early menarche results. Why? As an adaptive response of body to the central obesity in late childhood because of overfeeding. What happens is too much obese girls, they develop early menarche, early adrenarche, because of their body tries to, as an adaptive response, it increases the growth and bone maturation. If central obesity, in spite of that, is not compensated with increased bone maturation and increased height and all that, still then the next step, that is the premature pubertal changes happen and the early menarche takes place. It is due to the release of gonadotrophin as a protective mechanism. And this is what is called as smart escape. The body tries to escape from the risks of the central obesity. Body understand the central obesity is at risk for the health of girls. So these are the gene expressions and methylation. I will skip these 2 slides. It is little too complicated and too higher level. I don't know if you wish to go back, I can show you always, but this is the slide which shows that there can be differential gene methylation and expression between AGA and SGA fetuses. That is why AGA fetuses do better. SGA fetuses, so what your job is to maintain them in their Z score postnatal growth. If they cross the Z score, just take it that this girl is going to develop adolescent PCOS, and it is usually driven by fat excess in subcutaneous adipose tissue and insulin resistance and ectopic fat excess as well. So there is a reduced energy expenditure and low brown adipose tissue activity which is seen in PCOS. Now, how do you assess the reduced BAT activity? It is the low supraclavicular temperature during nighttime sleep and lower circulating CXCL14 markers in early morning. So these are the 2 markers. With these, you will know that there is a reduced BAT activity, and these girls. So this is a new biomarker, that is microRNA 451A, which has been identified, which is present in abundance in human circulation, and it is found to be lower in the girls with PCOS, and it inhibits THRSP in liver, which induces de novo lipogenesis in liver, so leading to central obesity, which leads to PCOS in adolescent girls. So this is a newer theory of understanding of PCOS, and it may have a diagnostic as well as therapeutic and prognostic importance. So this is the novel axis that has been researched out, and we have understood how central obesity is going through circulating MIR 451A, which is a new marker. So if you can detect this marker in the blood of girls with PCOS, you will know that they are at a higher risk of PCOS development and the central obesity and the metabolic implications. So what are the therapeutic implications? So if these mismatched girls are identified, you can give them metformin. So you should know that these are the girls who are going out of the Z-score chart, and it will reduce the central obesity, the metformin, because see, earlier we were not thinking of giving metformin to very young children, very young adolescents. But now with this understanding, maybe metformin will help, and early intervention may be considered in central obesity, and it will be possible to delay the menarche by giving this. When you identify early puberty, you can start giving this metformin. So this is just a recommendation, and after certain research that we have found. So this is the way to prevent PCOS of adolescents. The understanding has happened that if you find at risk individual of young girls, they should be reassessed 8 years post menarche for development of PCOS, and they can be monitored, counseled, and advised to maintain healthy lifestyle. It may prevent or reduce the full-blown, picture of PCOS. So it is important that pediatric group or adolescent group you identify at-risk girls and prevent them by making them run, exercise, and wherever possible, if you think that metformin is ideal, you can start metformin. So these are the various recommendations. I think all this will be discussed at your further lectures, and screening of young girls and all this. I'm sure this is going to be discussed, and this is a typical androgen like acne and hirsutism and obesity. All you can see here. These are the diagnoses. I think I will skip a few slides. Now we'll go to reproductive age. Reproductive age, there is a generalized improvement in the picture of PCOS. So natural history of PCOS goes becomes better at the age of reproductive age. But if due treatment is not started, or the persistent environmental factors don't decrease, then this group will experience higher incidence of metabolic disorders as well. So pregnant patients have higher incidence of metabolic and or medical and obstetric complications. So with this also understand that PCOS is very, very much having a lot of metabolic alterations even during pregnancy. Certain complications are more common like PIH, diabetes, all this you all often see. Now, these are the all complications, the miscarriage, preterm labor, hypertension, preeclampsia, and even the breastfeeding ability decreases because of overweight and obesity. So all these are happens in, now what happens in perimenopausal age? The phenotype of PCOS ameliorate with aging. But if you see larger ovaries in this age and persistence of these abnormalities, you should alert the physician. We should get alerted, and the perimenopausal period is associated with weight gain also. There is a mild hirsutism naturally coming also. There is both body fat and visceral fat tissue which increases. So we have to be on guard whether anything new is happening. It may be really serious. If not new, it is just the persistence of previous PCOS. It will slowly deteriorate, and weight excess per se is associated with increased cardiovascular risk, and which may be additionally aggravated by presence of other metabolic disturbances connected with PCOS. So most available data suggests that prevalence of these cardiovascular diseases and related long-term consequences in females seem to be lower than expected. And lifestyle interventions, rarely medical therapies are required, may be necessary to reduce metabolic. This is my another paper where I have proposed the HAPODS nomenclature classification. If you are interested, you may please go and read. So to come to the key messages, the metabolic implications of PCOS, understanding of PCOS. I think it is there where it was many years ago, but I think some of more research is happening that we know that it starts from in utero and it gets better near menopause. And both obese and lean PCOS will have metabolic risks. We must identify at-risk girls right from menarche to prevent these metabolic complications. As there is no cure, we better prevent this reproductive metabolic disorder for a healthy future generation, and more understanding in future may change current strategies. The only constant in this world is change, and we expect a very good and positive change in future in terms of understanding of PCOS and management of PCOS. Thank you so much. Thank you for your attention.
Dr. Kiran ma'am, you can conclude in a sentence Madam's talk, and we are running a little late. We have Dr. Kiran Chana.
Dr. Kiran. Dr. Anita, you'd like
really, yes, very rare you will get.
I think Anita ma'am.
Yeah. Yes, it was an excellent talk delivered by Dr. Suvarna. And we all know she has talked pure science, and science is always evolving, which she herself has mentioned in the end. And today, by listening to her talk, even people like who are supposed to have a great knowledge of endocrinology must have known several new points that she has brought in her talk, like features of metabolic syndrome in adolescents. We have not been looking into that point. And there are several things like prenatal factors. She has emphasized so much that we cannot do much after delivery because something that had to happen has already happened in the pregnancy. And regarding the biomarkers, that is becoming nowadays, by which we can diagnose and confirm the diagnosis of PCOS as early as possible. And taking care of these girls right from 8 years of age regarding therapy with metformin is something new which will be coming up, I think, soon in the future. And she has also talked about the novel axis. That is also very novel to every one of us. So thank you, Suvarna, you must have worked very hard on this point to collect so many of new research papers and making the people aware about all these things, which is more likely to be in clinical practice in next few years. So thank you, Suvarna.
Thank you.
Dr. Krishna Kumari and Dr. Kiran Mai for including.
Thank you so much, Dr. Anita. I think we should all thank Dr. Suvarna for her giving a complete review of PCOS. She has made a good introduction to what PCOS is today from so many years back. Thank you so much for your lecture, and thank you, Dr. Anita. We missed Dr. Kiran's comments. I think we move on to the next talk of the day by Dr. Abarani Sinha on making the diagnosis. And for that, I would like to invite chairpersons Dr. Leela Vyas and Dr. Jyoti Haq. Can I have the CV of Dr. Leela Vyas? Dr. Leela Vyas, she is once again known to all of us, and she is a former professor and unit head, and she has been she's an IVF consultant. She is a member of Research Review Board, SMS Medical College, Jaipur. She's a senior consultant at Cocoon Hospital, again, Jaipur. She is a senior consultant of aesthetic and cosmetic gynecology at Vyas Clinic, Jaipur. And she is a Dakshata and Lakshya mentor, NHM Rajasthan. She's been the chairperson of ISAR Rajasthan from 20 to 21, Vice President FOGSI 2018, President Nachi Rajasthan in 2016 to 17, President Jaipur OBGYN 2013 to 2015, and Secretary Jaipur Obstetrics and Gynec Society before that. Thank you so much, Dr. Leela, for accepting our invitation. And can I have Dr. Jyoti Haq? She is the ex-professor and HOD and of the Department of OBGYN and Government Medical College, Jammu. She has done a graduation and post-graduation at GRMC Gwalior, senior residency at Delhi Hospital, Kashmir, consultant at GB Pant Hospital previously, and she's now the president of Jammu Obstetrics Society. She has also been the secretary of IMS, and she has publications in various journals, examiner of MBBS and MD at different universities. She is both an undergraduate and a PG teacher, and her special interests are high-risk pregnancy and gynec surgeries. Thank you again, Dr. Jyoti, for coming over. And I request now to you all to introduce the speaker, Dr. Abarani Sinha, and the topic.
Good afternoon, everyone. At the outset, Dr. Jyoti, you introduced because there is some problem in my side in internet.
We can.
Dr. Jyoti? Okay, Dr. Jyoti is there or not?
We can hear you, Dr. Leela. You can continue.
Okay.
Am I audible? Yeah, Dr. Jyoti also is there. I'm audible. Yes, you are audible, Dr. Jyoti. Go ahead. Very good evening and greetings from Jammu chapter. I'm really honored and delighted to have an interaction with enthusiastic and very experienced professionals and stalwarts on this platform. A warm welcome and lots of good wishes. I'm now inviting Dr. Abarani Sinha, who has done MBBS, DGO with MS and FICOG. She's a professor and HOD OB-GYN of Muzaffarpur, ICOG Governing Council member 22, and Patna, President Patna Ops Gynae Society, Chairperson Quiz Committee, FOGSI, National Corresponding Editor Jogi, UG and PG teaching experience of more than 26 years, contributed chapters in FOGSI publications, joint organizing secretary, AICOG 2014, master trainer FOGSI, and special interest in high risk and vaginal surgeries, MS.
It's okay, madam.
Okay. Welcome, Dr. Abba.
Thank you so much, Chairpersons, Dr. Leela Vyas and Dr. Jyoti, for this kind introduction. At the outset, I'd like to express my sincere gratitude to the FOGSI President, Shanta Kumari Madam, and the whole team of FOGSI, the Secretary, Dr. Madhuri Patel, and especially the conveners, Dr. Kiran Mai and Dr. Krishna Kumari, for making me a part of this very prestigious National FOGSI CME. Well, I have been given the task, and I also pay my regards to the chief guests of today, Dr. Usha Sharma Madam, Pranam, and Dr. Chandravati Madam. It's a pleasure to be here, and also Dr. Nandita Palshetkar Madam. So I'm sharing my screen. Is it visible? Is my screen visible?
No, ma'am.
Oh, it's not visible. Okay. I'll do it again.
One small request, Abba ma'am.
Yes, I'll make it short. Sure. After such an elaborate discussion by Dr. Swarna Khadilkar Madam and such a interesting and informative lecture, I know my job has become quite easy. And I'll be talking about the diagnosis of PCOS. I'll be mainly touching on the clinical points because we have heard a lot about the etiopathogenesis. The epidemiology has already been described, and the history, we know that even before Steele-Levelton, the syndrome of PCOS was recognized. But we all have to understand that the word PCOS is a misnomer. It neither reflects the hyperandrogenism nor the metabolic derangement, both of which are essential for the diagnosis. The ovaries also do not contain the epithelial cyst, but actually they contain the antral follicles. The predisposing factors could be mainly the lifestyle, environmental factors, the genetics, the obesity, and the neuroendocrine, which has been so well described by my previous speaker. But we all have to have a very high index of suspicion for PCOS because, as already we have known, it has been associated with risk factors for cardiovascular disease like obesity, glucose intolerance, dyslipidemia, fatty liver, and obstructive sleep apnea. And therefore, we require evaluation and treatment of all girls who come with these symptoms. Insulin resistance is also a common accompaniment which can be present in both lean and obese women. And therefore, we need to do an early diagnosis and intervention so that we can optimize treatment, improve the quality of life, and timely manage these cases. Now, when it comes to the diagnosis, it is a condition which is very much underdiagnosed, and it is an unrecognized condition. Sometimes there is a delay in diagnosis. Also, it is poorly diagnosed, but at times even it is overdiagnosed. Many times the patient, they themselves diagnose PCOS and they come and tell us that I'm having PCOS. And then it becomes a difficult task for us to explain her that, well, you're not having PCOS. The relatives, they diagnose PCOS, the dermatologist diagnose, the sonologist diagnose. But when the patient comes to the gynecologist, I think we have to focus more on these patients regarding the follow-up of these patients, because we all heard about that, how these patients, they can develop metabolic syndrome. Now, there have been different diagnostic criteria which have been proposed. The one in 1990 by the NIH consensus, the Rotterdam criteria, and the AES definition. In NIH, two things had to be there: the menstrual irregularity or oligo or anovulation, along with clinical or biochemical signs of hyperandrogenism. And in Rotterdam criteria, 2 out of 3, like oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries by ultrasound. And in AES definition, it includes the hyperandrogenism was the key thing. Along with that, either oligoanovulation or polycystic ovaries. But in all these cases, we have to exclude other causes of androgen excess. So when the Rotterdam criteria is the most used criteria, and most of us are practicing, and most of the international consensus guidelines, they are recommending the Rotterdam criteria. And when we are taking this Rotterdam criteria, many of these patients can be diagnosed based on history and physical examination. The history is usually that of a irregular menses, and there may be clinical signs of hyperandrogenism like acne, hirsutism, or male pattern hair loss. Now, what are irregular cycles? I think this is the thing that we have to understand, that in the early pubertal years, because of the changes that are taking place, any irregularity in the menses in the first years post-menarche is a part of normal pubertal transition. If it is within 1 to 3 years post-menarche, we have to look at the cycles. If it is less than 21 or more than 45 days, we call it irregular cycles. And if it is more than 3 years post-menarche to perimenopause, then anything less than 21 or more than 35 is, or less than 8 cycles per year, is considered as abnormal. And 1 year post-menarche, more than 90 days for any cycle is considered irregular. If there is primary amenorrhea by the age 15 or more than 3 years post-thalarchy, then that also has been included as irregular menstruation. Now, clinical hyperandrogenism, already I mentioned, it may include acne, alopecia, male pattern hair loss, and hirsutism. If there are signs of virilization, it usually does not suggest PCOS. It usually suggests the possibility of ovarian hypertrichosis or an androgen secreting tumor. Many a times when these patients, they come to us, they have already undertaken some self-treatment. So it is very important to ask history about any self-treatment, because that can limit the clinical assessment. So these, when we are seeing this clinical hyperandrogenism, we have to use standardized visual scales when we are assessing them. And usually it is the modified Ferryman-Galloway score. And a cutoff score of more than 4 to 6 indicates hirsutism. But again, that depends on ethnicity, because this hirsutism, it is more in Southeast Asia and certain other races. And again, the terminal hairs are only relevant in pathological hirsutism. When we are looking at alopecia, then the Ludwig visual score should be taken. Now, in those patients in whom there are suspicion of PCOS, but there are clinical signs are not very clear, in those cases, we have to go for the evidence of biochemical hyperandrogenism, because it will help us in the diagnosis as well as the phenotype. We have to use standard measurements like calculated free testosterone, free androgen index, or calculated bioavailable testosterone. And again, the assays should be very much standardized, like liquid chromatography mass spectrometer and extraction chromatographic immunoassay. Tests like direct free testosterone assays, such as radiometric or enzyme-like assays, should not be used because they have got poor sensitivity, accuracy, and precision. So when we are going for the test for biochemical hyperandrogenism, again, history taking is very important. We have to inquire the patient whether she is taking any hormone or oral contraceptives, because this will alter the results. So if a woman is on hormonal contraception, they should withdraw the drug at least for 3 months or longer before measurement of the androgens. And if the androgens are levels are markedly above the laboratory levels, as I said, in cases of severe hyperandrogenism, we have to look for other causes of hyperandrogenism. Now, the polycystic ovaries, this is the typical polycystic ovary which is seen on transvaginal ultrasound, and it can be seen in many women who have irregular menses and hyperandrogenism. But this, we have to understand, this ultrasound features is a non-specific feature, as many women, even with normal cycles, can show cyst. And especially in adolescent girls, this is very important, that we should not use ultrasound as the diagnosis of PCOS if the gynecological age is less than 8. That is, if she is less than 8 years after menarche, because at this age, we find a high incidence of multifollicular ovaries. If the patient is having irregular menstrual cycles and hyperandrogenism, if there is a combination of the two, then also we may not need ovarian ultrasound, but if we get an ultrasound picture of PCO, that helps us to make a phenotype. That will help us to have a classic PCOS phenotype, because these patients, they have more of metabolic consequences than the women who only have irregular menstrual cycles and hyperandrogenism. The transvaginal approach for looking at the ovaries is always preferred if the patient is sexually active and if it is acceptable to the individual. Now, again, there are strict ultrasound criteria. It has been made very strict. Like if we are using ultrasound for the diagnosis, it should have a frequency bandwidth of 8 MSZ, and the threshold should be that there should be follicle number per ovary of more than 20 or an ovarian volume of more than 10 ml. Apart from this, we should ensure that there are no corpus luteum, cysts, or dominant follicles taken as follicle. And if we are using the older technology, then we should not see the follicles, but we should see the volume of the ovaries. The volume of the ovaries should be more than 10 ml. Similarly, when we are doing a trans-abdominal ultrasound, the reporting is best focused on ovarian volume with a threshold of more than 10 ml, given the difficulty of reliably assessing follicle number with this approach. In the reporting, one should include certain standards like LMP, the bandwidth frequency, the approach by which it is assessed, the total follicle number, the 3-dimension volume, the reporting of endometrial thickness, the 3-layer, and also if there is any other uterine or ovarian pathology. So therefore, the person who is doing the ultrasound has a need for training in careful and meticulous follicle counting per ovary in order to improve reporting. Now, anti-Mullerian hormone was also considered as a diagnosis tool for PCOS, but the evidence says that they are not yet adequate for diagnosis, and they should not be used as an alternative for detection of PCOM or a single test for diagnosis of PCOS. As I said, ethnic variation is very important. When we see our women of Southeast Asian, they have got increased central adiposity, insulin resistant, diabetes mellitus, metabolic risk, and acanthosis nigricans. Now, if we look at the different diagnostic criteria one by one, the hyperandrogenism has a good strength because that is one of the major clinical concerns for the patient. But the limitation is that the assays are not standardized across laboratories. And if we have the evidence of clinical hyperandrogenism, it is difficult to quantify them, and it also varies in different ethnic groups. And when we look at the ovulatory dysfunction, again, it is difficult to measure because many patients, even with anovulatory cycles, may have normal patterns. Coming to the PCO morphology, we all know the drawbacks in adolescent girls. Finding a multicystic ovary in an adolescent girl, it does not contribute to the diagnosis of PCOS, and there may be other conditions also which can mimic PCOS. So, as I said, according to the phenotype, depending on the findings, the clinical findings, we have the phenotypes A, which has androgen excess, ovulatory dysfunction, along with the polycystic ovarian morphology. This is the classic PCOS. Then we have the hyperandrogenic one, where it can be associated along with ovulatory dysfunction or with a polycystic ovarian morphology. And the D type is where there is no hyperandrogenism. It is ovulatory dysfunction along with polycystic ovarian morphology. Now, why it is important to know the phenotypes? Because if the patient presents with a classic PCOS, that is hyperandrogenism and anovulation with or without PCOS, she'll have more severe menstrual disturbances and hyperandrogenism. There'll be higher prevalence of total and abdominal obesity and metabolic syndrome. And these patients, they are at higher risk of type 2 diabetes mellitus and cardiovascular risk factor. Whereas those patients of ovulatory PCOS, that is those have hyperandrogenism and PCOS, they have lesser degree of hyperandrogenism and lower prevalence of metabolic syndrome and milder form of dyslipidemia. Whereas those women who have PCOS without hyperandrogenism, they have anovulation, minor menstrual problems, and then have a metabolic profile which is almost comparable to a normal woman. So before diagnosing a case of PCOS, we should exclude other conditions such as non-classic congenital adrenal hyperplasia. I think this is a condition which mimics PCOS, because in these conditions we can get hirsutism, we can get a typical PCO ovaries on ultrasound. And the other condition, because of anovulation or dysovulation, is thyroid disease, hyperprolactinemia, and even ovarian failure. Sometimes if a woman comes with amenorrhea, we should always do a routine urine pregnancy test because the patient may be pregnant. So these are the things which have to be excluded. And if the woman has severe hyperandrogenism and virilization, as I said earlier, it is very important to rule out serious causes such as androgen secreting ovarian and adrenal tumors and ovarian hypertrichosis. Now for non-classic congenital adrenal hyperplasia, they present with hyperandrogenism, oligomenorrhea, and polycystic ovaries. Though they are less common than PCOS, but it should be ruled out because there are risks that the offspring could be affected with the most severe classic 21 hydroxylase deficiency. And this is diagnosed by measuring the 17-hydroxyprogesterone, but a morning value should be taken at around 8 a.m. And if it is greater than 200 in the follicular phase, it usually strongly suggests the diagnosis, and this can be further confirmed by the ACTH stimulation test. In women with androgen secreting ovarian or adrenal tumors or ovarian hypertrichosis, they present recent onset of severe hirsutism along with progressive worsening of hirsutism, and signs and symptoms of virilization may be frontal balding, severe acne, clitoromegaly, increased muscle mass, or deepening of the voice. But here it is important to see the serum testosterone concentration because they are always more than 200 with ovarian tumors. And in adrenal tumors, we have to go for pH, dihydroepiandrosterone sulfate concentrations because they'll be found to be higher than 800 microgram per DL. So this is how we approach a case of patient in whom we suspect PCO. If the patient comes with irregular cycles and clinical hyperandrogenism, we have to exclude other causes and we diagnose. If there is no clinical hyperandrogenism, but then we go for biochemical hyperandrogenism and diagnose. And if there are only irregular cycles or hyperandrogenism, then we go for an additional ultrasound. But again, ultrasound is not used for diagnosis in an adolescent girl. And we have to exclude causes like TSH, we have to do TSH, FSH level, prolactin levels, and we have to rule out Cushing syndrome, adrenal tumors, ovarian tumors, if there is high level of androgens. LH and FSH.
Yes. Two more minutes.
Yes, 2 minutes, I'll be finishing. I'm just going to the last few slides. So diagnosis in adolescence, here we have to understand that hyperandrogenism is central to the presentation in adolescence. And it is based on the clinical and biochemical features in the presence of persistent oligomenorrhea, and PCO morphology is not used for the criteria in adolescence. In perimenopause and menopause, Swarna madam very nicely described that there is amelioration of symptoms. So here we diagnose depending on a presumptive diagnosis, which is based on a well-documented long-term history of oligomenorrhea and hyperandrogenism. Once these patients are diagnosed, I don't think I'll go through this slide. We have to monitor them for the cardiovascular disease risk, which includes measuring the waist circumference, the lipid profile, and the blood pressure, and knowing the glycemic status with the baseline levels of the blood sugar levels. Obstructive sleep apnea is again one thing which can occur along with, so we have to follow up and we see this. I think these will be discussed later on, and of course depression and all those things. So here I would like to put up certain key messages that accurate and early diagnosis of PCOS is of critical importance because of the potential long-term consequences. Currently, the ESHRE, ASRM or Rotterdam criteria are the agreed international diagnostic criteria for PCOS. And diagnosis of PCOS in adolescent is very challenging. Function should be considered, and ultrasound is not recommended in this period. And USG criteria are tightened with advancing technology, and AMH levels are not yet adequate for diagnosis. So thank you so much for giving me this opportunity. I hope I was in time.
Thank you.
Yes, ma'am. Thank you, ma'am. Thank you.
Thank you, Dr. Abha. Yes, everything has been covered. And your most important point that the clinical diagnosis is very important, total history and all, that we go with that. And in short, we can say that PCOS is the diagnosis of exclusion. Means so many things are associated. So a proper history and very particular tests are required to diagnose and then to treat. And definitely we need time. I would like to say that once that they are coming to the girls, coming to the gynecologist and straightforward say, I have PCOS. So they're coming with their own diagnosis, but we need a time with them to counsel them how to resolve their problem, and then to make the parents also to be comfortable that this disease is to be controlled by themselves only. Thank you, Kiranmai. Thank you, FOGSI, for giving this opportunity. Thank you, our President, Dr. Shanta Kumari, and conveners, Dr. Kiranmai and Dr. Krishna Kumari. Thank you very much.
Thank you, madam. Thank you, madam.
Thank you, Dr. Abha, for that very enlightening topic. I think it goes on, and at least we're trying to come one step forward. And thank you, Dr. Jyoti, for chairing the session. Thank you so much. And the next, I think I would like to apologize to Dr. Usha Sharma, Madam, and Dr. Chandravati, ma'am, for the delay in inauguration. You all understand how much there is to talk in PCOS.
Oh, Krishna, it was a pleasure to listen to these special talks. It was wonderful. So I thoroughly enjoyed the talk.
Yes.
Thank you, madam. Thank you so much. So we are moving on to the inauguration.
Hello.
We are going ahead with the inauguration. And I would like to invite all the, of course, I would like to invite first our President, Dr. Shanta Kumari, for the inaugural session. Our Secretary General, Dr. Madhuri. I would also like to invite our FOGSI office bearers, Dr. Hrishikesh Pai, President-elect, Dr. Alpesh Gandhi, immediate past President, our Vice President, Dr. Archana Verma, Dr. Basab, Dr. Bipin, Dr. Kavita, and most importantly, Dr. FOGSI Lewis, who is Vice President in charge for today's first series, and first of the series. Dr. Suvarna Khadilkar has already joined us. She's Deputy Secretary General. Dr. Aruna Suman, Joint Secretary. Dr. Parikshit Tank, Treasurer, and Dr. Niranjan Chavan, also I saw him. He is there with us, who is a Joint Treasurer. Thank you all so much for joining us today. And at the beginning, I would like to invite Dr. FOGSI. Are you there?
Yes.
Yeah, thank you so much, Dr. FOGSI. He is the VP in charge. Can I have the CV of Dr. FOGSI? Of course, he doesn't need much introduction. Dr. FOGSI Lewis is well known to all of us, and he's Vice President of 2021 ISAR National.
Krishna ma'am, invocation and President's video also.
Yeah, I think where he would be welcoming the audience first.
Yeah. Okay.
Dr. FOGSI, can you go ahead and welcome the...
Yes, good afternoon to all of you. Respected FOGSI President, Dr. Shanta Kumari, Secretary General, Dr. Madhuri Patel, and incoming President, Dr. Hrishikesh Pai, and immediate past President Dr. Alpesh Gandhi, my co-vice presidents Dr. Archana Verma, Dr. Basab Bibin Pandit sir, and Dr. Kavita Bapat, and also the Deputy Secretary General Dr. Suvarna Kadekar, Dr. Aruna Suman, Dr. Parishit Khan, Treasurer, and Joint Treasurer Dr. Niranjan Chauhan. On behalf of all of the office bearers, I today welcome all of you for this wonderful initiative by the FOGSI president and the team about the Quest Series 1. I think today I like to welcome, before telling anything, our guest of honors, who doesn't need any introduction, who is our not fatherly, we can tell motherly figures of our FOGSI Association, Dr. Usha Sharma Madam and Chandravati Madam. And we have got an expert of experts by Dr. Nandita Palshetkar on the specific topic of PCOS. The relevance is that whenever somebody comes to the gynecologist clinic, now what we are seeing that most of about 50% of the people, gynec patients complain that I have got PCOS. So that is how the people are either taking it as, some people are taking it as advantage of going for of that, but some people are getting terrified with that. So that is the relevance of the topic which has been chosen today. And the conveners, Dr. Krishnamari Madam and Dr. Kiran Mani, has chosen the faculties. We have got all the experts. We have already heard 2 speakers with experts, and we have got ranging from youngsters and covering from all the topics from pregnancy to adolescent to all the aspects of the PCOS we are covering. So I think I take this opportunity to welcome on behalf of FOGSI and all the office bearers for all of the faculties and our chief guest, expert of experts, and also all of you who are listening to that for this wonderful academic event. I'm not standing in between because we wanted to finish it because already we are late. I welcome once again for all of you for this wonderful webinar on PCOS.
Thank you, FOGSI.
Thank you, Dr.
Krishna, can I just address this? I am outside, so I have to just leave in 5 to 3 minutes.
Give us 1 minute for the invocation, then you can. 1 minute for the invocation first, please. Can we have the invocation?
Invocation video, please.
Audio visual.
Shriman.
Shriman.
Yeah.
Yes.
Lag it. Yeah.
Dear friends, FOGSians, and the women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a doctor and a woman myself, I have observed very closely how prevalent violence against women is across the strata of our society and the enormous impact it has on the health of our women. My theme for the year as the President FOGSI is FOGSI for all always, and Dhira, stop violence against women.
Dr. Shanta Kumari, who has relentlessly campaigned for the issues of girl child. I was happy to be the ambassador of FOGSI FOGSi in 2030, and I hope that me being an ambassador has motivated a lot of girls and many families.
Violence against women is a serious human rights violation, leading to injury and sometimes even death. Unfortunately, 1 in 3 women experience some sort of physical and sexual violence during their lifetime. Violence in pregnancy is also widely prevalent, leading to unwanted pregnancies, unsafe abortions, neglected pregnancies with no antenatal care, all these contributing to maternal morbidity and near miss. As obstetricians and gynecologists, we have a great opportunity to assess and support women who experience violence because of the unique opportunity where we get to see them during the pregnancy, during the family planning visits, during their annual checkups, and multiple other times when they come to us. I strongly believe that by eliminating the violence against women, we are not only reaching the SDG goals, but also creates a just and equal society for our women. Until we make men and boys active partners, we can never end the violence against women. In an endeavor to sensitize our own fraternity, my initiative of Dhira was started to eliminate violence against women.
I completely support her vision and mission as President FOGSI and also especially support her campaign, Dhira, Stop Violence Against Women.
It was in 2016 at the launch of Dhira. We brought together the police, the obstetrician gynecologists, the National Commission for Women, the women and men on one single platform to wear orange and say no to violence against women. We organized the public forum and cyclothon to launch Dhira. In 2017 at the FOGSI FIGO Congress, we partnered with men and organized the bikeathon and the flash mob. The high point of Dhira was at the International FIGO Congress at Rio, Brazil in 2018. The declaration on no to violence against women was signed with FIGO and WHO. It was here global societies pledged their support to end this violence against women. The Dhira campaign and march at the World Congress of FIGO in Rio in 2018 got wide international publicity. No change is possible unless the young minds adopt it and make it a part of their life. Young minds are open and creative. They accept change. FOGSI has always worked with adolescents for their health and well-being. Dhira this year adds a new page. I'm happy to share with you all that we are launching the Dhira online school certification course across the length and breadth of our country in all the schools. FOGSI for all always. Dhira, stop violence against women.
Shanta, are you there?
Thank you, Krishna. Shall we?
Go ahead. They are going ahead with the lamp.
Yeah.
Can we have the CV of Dr. Shanta?
Krishna, thank you very much. I don't think I need any introduction.
Yeah, you can talk to the
Thank
CV
you.
on the...
It's okay. I
Yeah.
think I would at the outset thank our guests, seniors, Madam Chandravati and Usha Sharma Madam, for gracing the occasion. And my dear friends, Rishikesh, Madhuri, and my whole team of Vice President. FOGSI is here, who's in charge of this program, and all the other Vice Presidents. And we have Kiranmai and Krishna Kumari, who are here, who are conveners for this program. We did have a small setback this year with the third wave hitting us, but we are very happy that we have been able to put it behind us, and luckily the country is reeling back to normal. So I'm eagerly looking forward to meet all of you physically in Indore AICOG conference. Before that, we shall meet in Ludhiana conference physically. And yes, so before we could actually convene with our physical meetings, we thought, let us keep ourselves busy with our academic quests. So PCOS series has started today, and I congratulate the whole team of office bearers and the faculty for coming together and joining us. We have with us Niranjan Chavan, our joint treasurer, and other office bearers. Suvarna Kadilkar was there with us today as faculty. Thank you all for being with us. It's really wonderful when we share knowledge and try how best we can take care of our women. And I think this year the whole team has been around Dhira, Stop Violence Against Women. So Sriman and the team actually, as soon as they hear of something, I think the first thing which comes on their brain is the Dhira video. So I'm extremely sorry and apologize for this small lapse. And thank you to each and every member of FOGSI for bearing with us in the difficult times and the difficult decisions. We are sure things are going to be better, and we shall meet soon. And wish you all the best for this wonderful conference which is happening. And I'm sure we all will, all the delegates and faculty will benefit from the knowledge which has been shared by all of you. Thank you very much.
Thank you so much, Shanta. And it's always a pleasure listening to you. And of course, we don't need to introduce you at all. This is your own program. So we are a part of your program. Thank you for giving us the opportunity to be with you today. And we move on to inviting our guest of honor today. I have Dr. Chandravati, Madam, with us today. I think like Shanta already said, thank you so much, Madam, for gracing this occasion. Can we have the CV of Dr. Chandravati, Madam?
I think, Krishna, what Shanta said, we don't need any CVs today.
Madam, you need, I think we should introduce you. Shanta, of course, it's her program, so it's okay. So, of course, everybody knows you. There's nobody who needs to be again introduced to you. We have known that you are the Professor Emeritus as Department of Obstetrics and Gynae, KG Medical College, and you are the Proprietor Director of Krishna Medical Center, Lucknow, and you're also the Managing Trustee of the same center. You have been a Secretary NGO of Women's Health Empowerment and Education, Lucknow, and a patron of Indian College of Maternity and Child Health. So with this, I think I will hand over to you, Madam. We will listen to you and your words of wisdom.
Thank you, Krishna, for
Chandravati Madam.
Introduction. Yeah.
Chandravati Madam, Madhuri Patel and I always have great regard for you, Usha Madam, and all seniors who have been guiding FOGSIans.
I think it is your love and affection which keeps her going. I think every day I count, and it is only your love and love of everyone, each FOGSIan, which keeps us going. So it is pleasure to be associated with any FOGSI program. And when Kiran talked to me, I said, of course I will be there. If it is Shanta's program, I would never miss it. So FOGSI had been a part of our life, which is each and every cell of our body. And we can never forget what FOGSI has given to us. All this name, fame, everything is only through FOGSI. And thank you, Shanta, for remembering us, and Kiran and Krishna for having us today as a guest of honor, because I don't think I'm guest of honor. I'm a part of FOGSI, and I always feel I'm a part of FOGSI. And my blessings are to all the FOGSI office bearers, Shanta, Rishikesh, Alpesh, Madhuri, Swarna, and all the vice presidents, everyone, each one, I bless you all to keep on going this way. And I congratulate you for starting this academic quest, a monthly program. And I'm sure each one, a member, is going to benefit from this. And I really appreciate taking this wonderful project today, the PCOS, which is one of the most difficult subjects I think one needs to talk. And every day you talk, you think you know so much less about it. And the two topics I heard in the morning, just before this inauguration, I was really amazed, and it was such wonderfully prepared. And I'm sure all the other speakers are going to be there, and with experts like Nandita and so many experts of the experts are there. I'm sure that the whole session is going to be so wonderful, and I will be there all through till I can sit over there. And I wish you, Krishna and Kiran, of success, great success for today's program. And I wish FOGSI for coming Quest programs all the success. So bless you all, be happy, be healthy, and keep on working. Thank you.
Thank you. Thank you so much, Madam. I think it's a pleasure listening, although it's only a few words. It's really been a pleasure listening to you. Can I have the CV of Dr. Usha Sharma, Madam?
वो दिख गया, अमृता दिख गया.
Yeah. Good evening, Madam. Again, it's a pleasure having you with us today. Again, don't say that you don't need introduction.
Yes, please. पढ़ लिया सबने.
So I think
Or
we have to
we
tell
are
that we had been
really, as
awarded.
Chandraji said, we are part of FOGSI only.
True,
So
true.
I don't think you should not waste much time on this.
Yeah, please, madam.
Thank you
Please
so
go
much.
ahead. We would prefer to listen from you.
Thank you very much. We all know our beloved President, Dr. Shanta Kumari, who is a very dynamic, dedicated, and has an exemplary vision of all these activities of FOGSI. And then it has been backed by our Secretary General, who is a very loving, affectionate, and down-to-earth person, Dr. Madhuri Patel. The Vice President in charge of this program, FOGSI Lewis, we all know he is also a very, very hard-working person. Then we have Nandita with us, who is expert of experts. मैं नंदिता के लिए हमेशा ये कहती हूँ, she is a lady who has beauty with brains. And then our convener, Dr. M. Krishna Kumari, as well as co-convener, Dr. Kiran Mai. I'm really seeing your hard work in the group. You are putting the messages, you are responding to the messages, and I really appreciate your effort, whatever you have put for this webinar. And then we have got learned speakers. 2 of them we have already heard, and there are many more, and they will be giving their talks. Those deliberations will... Okay.
Sorry, madam.
Okay. It gives me great pleasure to be with you all this evening on the occasion of FOGSI virtual webinar Quest-1, in which we will discuss PCOS across the ages. And we know that PCOS is very common endocrinopathy in women of reproductive age. As Chandraji also said, that it is a very, very important subject, and most of us do not know the exact etiology. However, both the environmental as well as the genetic factors play an important role in the etiopathogenesis of this disease. Now, we know that PCOS women have increased factors for reproductive as well as cardiometabolic comorbidities. Now, insulin resistance as well as hyperandrogenemia, which was also taken up by the Suvarna just before this inauguration, forms the pivot around which the whole pathophysiology of the disease rotates. We have seen that advanced glycosylated end products are responsible for the various end metabolic consequences like early onset of diabetes, obesity, and hypertension. We have also always seen that there has been quest amongst the gynecologists as well as the endocrinologists, unveiling the mystery of PCOS and finding a permanent solution to the reproductive morbidity of PCOS, like infertility and early pregnancy loss. And again, also I will say even the cosmetologists are very worried, and the gynecologists are also very much concerned about the hirsutism associated with PCOS as well as other issues in the young girl. So it's really a very, very important topic which is to be discussed today. And I'm sure that the deliberations, and today I am also seeing that we are also going to discuss new theories about the homogene mutation as well as the gut microbiome alterations, which are new things coming up and are very helpful. And I will say that we know that it is really a great puzzle, but we have to solve it. And then by organizing such webinars again and again, I think that most of the questions will be answered. And I will like to congratulate Dr. Shanta Kumari, Dr. Madhuri Patel, Dr. FOGSI Lewis, Kiran Mai, and Dr. M. Krishna Kumari, Nandita, and the whole team for organizing such a topic, a webinar on such a topic which is so important and which is so fruitful for every one of us. And I really accept the thing that PCOS is a riddle wrapped in a mystery inside an enigma. And it's really very, very true. And I'm sure the deliberations will be very fruitful for everyone. And most of our delegates will find many answers of the questions which they have in their mind. With these words, I wish this program a great success. Thank you very much, Shanta and the whole team, for making me a part of such a prestigious webinar. Wish you all the very best. And I'm sure under the leadership of Dr. Shanta and Dr. Madhuri Patel, FOGSI will go up and all the academic activities will reach the apex. Thank you very much.
Thank you. Thank you so much, madam. It's such a pleasure hearing you, and you're looking at the beautiful background with that speaks what you are, your background. Thank you. Thank you so much for being with us today. And can we have Dr. Hrishikesh Pai? I think he was with us.
Yeah, I'm there.
Yeah.
Hello, Rishikesh.
Hi.
Sorry,
Madam.
I didn't see you.
No problem, madam.
You are our president-elect, the great person.
No, I am part of the family, and you don't have to introduce me. Just you know, Rishikesh is enough. Can I talk? Don't worry about the introduction.
Okay, please go ahead and say a few words.
I'm really grateful. Dr. Shanta Kumari is my little sister who is now the president of the federation, and we have the two very, I would say one of the mother figures of our organization, Dr. Usha Sharma, Dr. Chandramati are there, and of course Dr. Kiran Mai and Krishna Kumari have organized this program. My very good friend Madhuri Patel, our first dynamic secretary general, is there, and Faisal Louis and all the other people are there, and of course my very important friend and colleague Nandita Palshetkar, who is also there with us, and a lot of others like Subarna Khadilkar, etc. are there. So I'm really thankful for you to invite me here. Talking about PCOS, it is for me, of course it's bad for the patient, but it's the best thing as far as the infertility specialist is concerned. Because in my practice, in 3 attempts of IVF, at 95% people I can achieve pregnancy in PCOS. Very easy. It's a very easy to achieve pregnancy in a PCOS patient, and especially because of my practice in the Mumbai and in Delhi. Over the years, in the north there is some high incidence of PCOS. Every second patient is a PCOS, and because of that, the pregnancy rates are better because the whole IVF is based on the number of eggs. More the eggs you get, more the embryos you get, more the embryos you get, more the easy way to get them pregnant. So because I am only focused on the pregnancy, I know that there's a cardiometabolic component, and going forward they have a higher incidence of diabetes, heart disease. But my focus in my specialty is pregnancy. Another thing is that the IUI is very difficult. So because there's always asynchrony between the ovulation and the endometrium, which is bypassed in IVF. Because in IVF we freeze the embryos, then we do the transfer in the next cycle. And in my practice, I always scrape out the endometrium because there is an end organ problem also. Because of the hyperplasia, there is an end organ receptivity problem. So it's very easy. I stimulate them, I freeze the embryos, and I scrape out the lining, and I transfer them in the next cycle. So for me, it's easier to make them get pregnant by IVF than it is by IUI. So this is the second point. And there are 5% chronics who don't become pregnant after 3 attempts. And these are the problem child. Most of them most of the time I'll get immature eggs, or I'll have very poor fertilization. And maybe the only one thing where I use is steroid. So if I have a chronic patient, I give them steroid for 1-2 months, and then I do the IVF and I get them pregnant. Otherwise, these 5% chronics, they ultimately land up in egg donation. So this is how the PCOS story is for me. Very simple, very easy. It's a piece of cake according to me. Thank you very much for calling me here and allowing me to share some experiences in PCOS, and wish you all the best for the program. Thank you.
Thank you. Thank you so much, Dr. Hrishikesh, for giving us some extra insights and inputs regarding infertility and PCOS. It was really worth the pearls you have told us. Thank you so much for joining us.
Thank you. Thank you.
And now I would like to invite Dr. Madhuri Patel, our very sweet and dynamic secretary.
Krishna, no CV.
I want to introduce you.
No CV.
Please go ahead with your.
Yeah. Thank you, Krishna. Honorable dignitaries on dais and off the dais, very good evening to all of you. On behalf of FOGSI, it is a great honor for me to propose vote of thanks for the very important virtual CME on Quest-1 PCOS across the ages. We would like to thank our most dynamic president, Dr. S. Shantakumari, for conceptualizing and supporting wholeheartedly today's program. We would like to express our sincere gratitude to our guests of honor, teachers of teachers, and our mentors, always eager to guide us, Madam Professor Usha Sharma and Madam Professor Chandravati Madam. They are really unique, and I had opportunity to work under them, and they are really unique. They are very encouraging, and they are always with us. And therefore, Madam, both the Madams, I would like you to always bless us. That is especially me and all the FOGSI members, so we can continue to work, for the women's health. Then we have our, I would like to further extend a hearty thanks to our president-elect, Dr. Hrishikesh Pai, who has really told us about the PCOS and the infertility and how simple. He said it is a piece of cake to treat these infertile women. So this is very, very good input. Then our immediate past president, FOGSI, Dr. Alpesh Gandhi. And of course, we have Dr. Nandita Palshetter, past president, FOGSI, and today's expert of expert in this PCOS, for sparing valuable time and giving us invaluable inputs. Then we have our deep, sincere and thanks and appreciation to our vice president, especially Dr. Tracy Lewis, who is today's coordinator. I will not say coordinator, but the VP in charge. Then Dr. Archana Base, Dr. Basam Mukherjee, Dr. Bipin Pandit, Dr. Kavita Bapat, and our Deputy Secretary General, Dr. Suvarna Karijar, whom we have heard, Dr. Parishit, Treasurer, Dr. Niranjan Chavan, and of course, I cannot forget, Dr. Aruna Suman, and, for their continuous support for this program. We would like to thank all our esteemed experts, speakers, chairpersons, moderators, and panelists for sharing their expertise and experiences. Of course, we have shared about Suvarna and Dr. Abbas Singh has shared with us, and others will be sharing with us to reduce the burden of PCOS and their consequences. We would like to thank our conveners, especially Dr. M. Krishna Kumar and Dr. Kiran Main. Along with FOGSI team, they have really worked hard for this virtual CME tirelessly and making this a grand success. We would like to thank all the esteemed delegates who have joined with us virtually with great enthusiasm in making this CME a grand success. Special thanks to Mr. Tirupati from MITI for the technical support and managing the event beautifully. Tirupati, we have become really fan of you, and we are doing so flawlessly all the CMEs and one virtually. And my sincere thanks to Dr. Shanta Kumari and the organizer for giving me this opportunity. Thank you once again.
Thank you. Thank you so much, Dr. Madhuri. I think I would like to thank all of you seniors who have been in FOGSI office bearers who have been with us today and has made this PCOS a wonderful program. You have added beauty to and you have given us very good wise I would say, some pearls of wisdom to our already existing knowledge of PCOS. Thank you so much, and we are looking forward for the rest of the program. And I would like, for this rest of the program, I would like to invite first Dr. Kiranmayi. Can I have Kiranmayi?
Ma'am, no need, ma'am. We are running late.
I will
Okay, fine.
just
Only
ask
one
an
word.
excuse, dear. I will just ask an excuse. I
Sure.
told Kiran that I have to go. Thank you so much. But I am proud of Dr. Chandravati, who is our leader and such a wonderful person. And I'm sure she will be there. Very sorry. I will really miss it. But I think Kiran and Krishna, can we get the record? Record. Okay. Thank you so much once again.
उषा तुम आराम से जाओ, मैं बैठी हूँ तुम्हारी जगह.
अरे आप तो हमारी सब कुछ हो. आप कहते हैं ना छत्र छाया में ही तो हम आपके हैं.
नहीं नहीं, हम देर जाओ जाओ तुम आराम से.
Thank you very much. Thank you very much. Okay,
Thank you, Doctor. Thank you, madam. I would like to invite Kiran. I know I don't want to say anything about Kiran Mai except one sentence, that she has now been promoted as a professor, and now she is Professor Kiran Mai, working in government setup. Congratulations, Kiran, and I request you to take it forward from here.
Yeah. Can I have the next session slide, the fast track sixer in PCOS? Dr. Rakhi also is here because Dr. Badnakini madam has told her about his inability to join. Welcome, Dr. Rakhi, for the panel. So the fast track sixer is 6 talks in 10 minutes. This is really, quite a short time, but we believe that our experts today who are there are so good that they would edit out all the, filter us the best information and give it in a very crisp manner to all of us. Without further delay, can I have Dr. Nandita madam's slide, who is today expert of experts for this whole session? Shriman? Yeah, Dr. Nandita madam again needs no introduction. She's a beloved past president and so many things to all of us. Apart from that, madam is such an eminent IVF specialist with more than 30 years of experience. She's a medical director, Bloom IVF, heads 7 centers all over India, and specialized in ART from world famous IVF units. She had been a leader of so many organizations, including our FOGSI, AMOGS, MOGS, President IAGE, President-elect ISAR. She's member of SSB PCPNDT Committee 2021, Uterus Transplant Committee, ART Bill, PCPNDT Committee, Member Surrogacy Bill of 2016, Chair Steering Committee of Manyata Project, Government of India Committee on Midwifery, Caesarean Section, and awards received are, I can't even start because there's so many. CME Dronacharya Award for Exemplary Contribution Towards Gynecology and IVF 2021, Dr. B.N. Purandare Outstanding Service Award, MOGS Award, and CME Excellence Award, Inspiring Gynecologists of India Award, and Bharat Gaurav Award 2014. Then Frost and Sullivan Best IVF.
Thank you, Kiran Mai. Thank you.
Ma'am, I can go on and much more than this. We all love you. Thank you, ma'am, for being here. Yes, ma'am. The first talk.
Sorry.
Yes,
yeah. Please go ahead.
Yes, ma'am. Then I'd like to introduce the chairperson for the first talk, Dr. Umayal. Again, a very dynamic person from Kanchipuram. She's presently the secretary of the Kanchipuram Society. She's also gold medalist and founder secretary of Kanchipuram Society in 2019 till present. President-elect of IMA Tambaram. She has taken over, I think, recently. Welcome, Dr. Umayal. I request you to introduce and invite our speaker, Dr. Alka Pandey, for her talk.
Thank you, Kiran Mai, for those lovely words. I would now welcome Dr. Alka Pandey, Associate Professor and in Department of Ops and Gynetics, Patna Medical College, Vice President-elect FOGSI 2022, Member Governing Council, ICOG 21-22, Chairperson Practical Obstetrics Committee and FOGSI 2015 to 17, National Corresponding as Editor of Jogi 2017 and till 23, President Patna Obstetrics and Gynetics Society 12 to 14, Joint Organizing Secretary, 57th ASCOG 2014, and Organizing Chairperson, FOGSI 2014. We welcome you to give your talk.
Thank you. Thank you, Chairperson, for the kind introduction. Good evening, everyone. And thank you, President FOGSI, Dr. Shanta Kumari, Secretary, Dr. Madhuri Patel, conveners, Dr. Kiran Mai and Dr. Krishna Kumari, and for giving me this opportunity, and my utmost regards to Madam Chandravati, Madam Usha Sharma, and Dr. Nandita Parshidkar. So my talk is polycystic ovary syndrome, pregnancy concerns. Can you see my slides?
Yes, ma'am. Yes.
Okay.
Yes.
So polycystic ovary syndrome is a heterogeneous disorder consisting of clinical or biochemical hyperandrogenism with ovulatory dysfunction, ruling out secondary causes for the same. Pathophysiology is multifactorial, involving endocrine, metabolic, genetic, epigenetic, and environmental factors, and the prevalence is 6% to 15%. There is peripheral.
Can you make it a slide?
Yes, I'm making it. The pathogenesis is peripheral insulin resistance, resulting in hyperinsulinemia, which decreases the sex hormone binding globulin production by the liver, giving rise to hyperandrogenemia. Then there is increased ovarian production of androgens and impaired secretion of LH, FSH. And as a result, there is oligoanovulation, hyperandrogenemia, and oligoanovulation. They cause PCOS. Now, there is an increased risk of pregnancy complications in PCOS, hyperandrogenism, and insulin resistance from the metabolic hallmark of PCOS women. Superimposed obesity has additional insulin resistance contributed by excess adipose tissue. Baseline insulin resistance seems to be exacerbated with entry into pregnancy. Now, pregnancy issues with PCOS are anovulatory cycles leading to subfertility, increased early pregnancy loss, increased gestational diabetes mellitus, increased PIH, increased preeclampsia, preterm delivery, and increased birth of small for gestational age babies. Now, early pregnancy loss may be due to increased androgens, endometrial dysfunction, impaired fibrinolysis, insulin resistance, and obesity. And we have taken a study, meta-analysis by KM Tanveer and Lutfur Rahman, where this finding is endorsed. GDM complicates 40% to 50% of PCOS pregnancies. There were 12 studies which investigated the association between PCOS in pregnant women and developing GDM. These studies assessed GDM in 1,676 women with PCOS and 10,230 women without PCOS. Pooled results showed that women with PCOS are more likely to develop GDM in comparison to controls. Then HTP occurs in 8% of PCOS pregnancies. Again, regarding this study, they found that they investigated 12 studies, the association between PCOS in pregnant women and developing PIH in 1,234 women with PCOS and 8,293 women without PCOS. Pooled results showed that women with PCOS are more likely to develop PIH in comparison to controls. Then PCOS and preeclampsia, again the same findings. 7 studies investigated the association between PCOS in pregnant women and developing preeclampsia. These studies assessed preeclampsia in 514 women with PCOS and 1,562 women without PCOS, and the pooled results showed that women with PCOS demonstrated a significantly higher chance of developing preeclampsia when compared with controls. Then preterm labor complicates 6% to 15% of PCOS pregnancies. And Dr. KM Tanveer and Mohammad Rahman have found that there were 11 studies which investigated the association between PCO in pregnant women and developing premature delivery. These studies assessed premature delivery in 1,423 women with PCOS and 9,714 women without PCO. Pooled results showed that women with PCOS have greater risk of premature delivery in comparison to women without PCOS. Then PCOS, small for date fetus. Then in this meta-analysis, there were 7 studies which investigated the association between PCOS in pregnant women and giving a low birth weight baby. These studies assessed low birth weight baby in 268 women with PCOS and 804 women without PCOS. And the pooled results showed that women with PCOS have greater risk of giving birth to low birth weight babies in comparison to women without PCOS. Now, newborn complications in women having pregnancies with PCOS, high perinatal mortality, more congenital anomalies, lower Apgar scores, and more frequent admission to NICUs. Then here I'm going to quote a few studies in the literature. This is a meta-analysis by Lucinda E. Jerclough, which was published in American Journal of Obstetrics and Gynae in 2011. And they found that PCOS in pregnancy was associated with higher rates of gestational diabetes mellitus, PIH, preeclampsia, preterm delivery, cesarean delivery, operative vaginal delivery, small for gestational age babies, large for gestational age babies, but only gestational diabetes, pregnancy-induced hypertension, preeclampsia, preterm delivery, and SGA infants were found to be statistically significant. Yet another study, a meta-analysis of pregnancy outcomes in women with polycystic ovary syndrome, which was published in review Human Reproduction Update in 2006 by CM Boomsema, and he found that women with PCOS demonstrated a significantly higher risk of developing GDM, preeclampsia, PIH, preterm birth, and had a higher risk of admission to neonatal intensive care unit, higher perinatal mortality, and in conclusion, women with PCO are at increased risk of pregnancy and neonatal complications. Yet another study by June J. Quinn, published in Review Reproductive Biology Endocrinology in 2013, obstetric complications in women with polycystic ovary syndrome, systematic review and meta-analysis, and they had 27 studies involving 4,982 women with PCO, and 1,19,692 controls were eligible for this meta-analysis, and they also had the same finding, significantly higher risk of developing GDM, PIH, preeclampsia, preterm birth, cesarean section compared to control. Their babies had a marginally significant lower birth weight and higher risk of admission to NICU. Now, treatment. Optimal antenatal care should be the aim to detect risk factors before and during pregnancy. So, this is a summary of pre-pregnancy, antenatal, and postpartum recommendations for women with PCOS. Pre-pregnancy, if she is an overweight or obese woman, consider weight reduction, optimization. Type 2 diabetes mellitus, screening with OGTT, HbA1c, hypertension, optimize blood pressure, adjust medication. In pregnancy, general health has to be taken into consideration. Prior medical history of great importance, increased prevalence of comorbidities. Then weight gain, encourage in adherence to weight gain recommendations in pregnancy and gestational diabetes, screening in the first trimester. If negative, repeat screening in gestational week 24 to 28 weeks with OGTT. Hypertensive disorders, checkup according to local guidelines. Preterm delivery, attention to signs of cervical ripening, preterm labor. And postpartum, general postpartum, considered need of follow-up, weight reduction, rule out type 2 diabetes, then breastfeeding problems, and postpartum depression. Then treatment, weight gain goals. With women with PCO gain more weight during pregnancy than women without PCOS. Excess weight gain in pregnancy is associated with poorer outcomes. Close monitoring of weight is advisable to prevent excess weight gain. Healthy food intake with minimal intake of refined sugar and saturated fat is advised. And Metformin has been shown in 3 randomized trials to reduce late miscarriage, preterm births, and less gestational weight gain. But there's a meta-analysis by Hong Zhuo, effect of metformin intervention during pregnancy on the gestational diabetes mellitus in women with PCO. And they have found that metformin did not significantly have effect on GDM with PCOS, though more multi-centers RCTs still need to be investigated. Case reports, clinical and epidemiological studies report on less breastfeeding among women with PCOS. And to conclude, there is evidence that women with PCOS, especially those with overweight and obesity, run an increased risk for gestational weight gain and common pregnancy complications. Diet and lifestyle modifications to optimize weight control before pregnancy and adjusting treatment for comorbidities is of importance. Preconception and antenatal screening for diabetes and hypertension is recommended. Metformin should not be used routinely in pregnancy. Decreased breastfeeding is probably linked to pre-existing overweight and obesities, and studies on emotional well-being and psychological well-being during pregnancy and postpartum is lacking. Thank you very much.
Thank you so much, ma'am. It was exactly 10 minutes and thank you so much. Wonderful inputs. Dr. Umayal, if you want to say a sentence and then.
Yeah, actually, like the number of PCOS is on the increase, and so focusing on these patients and managing them efficiently in the antenatal period will go in a long way to take care of so many complications which can come out of PCOD. So a PCOD patient becoming pregnant, we have to increase the monitoring and make sure that the outcome is much better than it could be. Thank you.
Thank you. Thank you, Dr. Umayal. Next we have, do we have Dr. Seshasai, sir? Did he join us? Dr. Umayal, I'll request you to introduce Dr. Krishna Kumari also. Please.
Okay, madam needs no introduction. Everybody knows her.
Thank you. Thank you so much, Dr. Umayal. I think already you have introduced me, Kiran.
Yes, ma'am.
Yeah, Dr. Krishna, just few words. Okay, Madam Krishna Kumari, Madam is with 30 years of obstetric and gynec practice, with 25 years of teaching experience, with a governing council member of ICOG, with national corresponding editor Jogi, national coordinator, treasurer, secretary and president of OGSH 17 to 19, vice president, TCOG, and she has a decade of experience as scientific chair for so many conferences in national and international levels. And she's also contributed to various textbooks like FOGSI, FOCUS and ICOG campus. Over to you, Krishna Kumari. It is a pleasure introducing you.
Thank you. Thank you so much. I think, thank you, Dr. Umayal, and I think I should thank Dr. Nandita for chairing this session along with you.
Second, ma'am, Dr. Nandita, ma'am, I think madam wanted to
say a few words.
Yes, actually. Do we have Nandita, ma'am, here? Madam has joined, I think.
Yeah, before the session started, I heard her.
Yes, ma'am. Meanwhile, if she joins, we can have her.
Okay, no problem. Can I share my screen? Thank you, Dr. Umayal, for that kind introduction.
Yeah, please go ahead. Yeah. Waiting to hear.
Oh, thank you. So my topic today is the long-term consequences of PCOS. As you have all heard, Dr. Suvarna, she has already touched upon to some extent regarding this long-term consequences of PCOS. And Dr. Alka has spoken about the consequences in pregnancy. So my job has been made much easier. So I think there are a lot of things which are interlinked in PCOS, and it's very difficult to identify the factors, whether they're exclusively the causative factors or they are coexistent factors for many of the problems. So basically, I thought I should make it as can we have some causal links between the condition and PCOS per se? Are there any specific screening methods, and can we do anything about it to prevent it at least from happening? So coming to the most common presentation that we know about is the overweight or obesity. It has a bidirectional relationship, whether it is causing PCOS or PCOS causing it. We have absolutely no clear-cut idea. It is seen in almost 60% of these women, and more in those women who are having a hyperandrogenic phenotypes. And it has a genetic predisposition, and there is an increased risk of metabolic dysfunction, more associated with central obesity. Then, like Dr. Alka has already said, the increased pregnancy complications, eating disorders, depression, and anxiety. So coming to a disease or disorder, specifically diabetes, there is data that supports that reproductive age and perimenopausal and menopausal women with PCOS do have an increased risk of developing IGT as well as diabetes mellitus per se. And more so, women in Asian subcontinent who almost a 5.2-fold increased risk of developing IGT. And also there is a cross-sectional studies which show that this at present, this impaired glucose tolerance is not only in obese women, but it is also seen independent of obesity. There is no such clear-cut link between hypertension and PCOS because the reported prevalence is very much varied, and there is no continued risk of hypertension which has been shown linked to PCOS, and it is independent of BMI after menopause. And of course, in adolescence, the data regarding hypertension is very, very, very limited. Coming to dyslipidemia, when they have matched the studies on BMI, they have found an association between PCOS and the presence of elevated LDLC as well as non-HDLC. Whereas the HA phenotype are the ones which are associated with a higher degree of dyslipidemias, and they also have a very low HDLC. So we have to, of course, as Dr. Suvarna rightly said, they are the more significant ones, whereas the non-hyperandrogenic phenotypes are the less significant ones. They are associated with less metabolic issues. Coming to metabolic syndrome, we know it is a cluster of metabolic disturbances. And even in young adults with PCOS, the prevalence is as high as 30%, and there is a 2 to 3-fold increased odds compared to the controls, such as the high incidence of metabolic syndrome associated with PCOS. And whenever there is a metabolic syndrome, we all know that these patients also have, when we look at the risk factors, they also have a high risk for developing cardiovascular disease. So these are the women where we have to take a detailed history about the risk factors at the first time we are going ahead with the initial diagnosis. And then we also have to look at any early onset cardiovascular dysfunction should be looked at. So there is a cardiovascular disease as well as a cerebrovascular disease events which can be happen, and the endpoints can be anything from getting admitted for an unstable angina to a non-fatal stroke or an MI, or even leading to even death. So the cardiovascular profiles are variable based on the phenotype as well as the age, the ethnicity, as well as the BMI of the individual. And there is a considerable increased risk, almost 7.4 relative risk of developing MI in those patients when you are looking at those age-matched reference. So this WISE study has also shown us that there is a close link between cardiovascular events, especially in the post-menopausal women. Coming to risk factors for VT, there are these risk factors which are coexistent with PCOS are also a causative factor for the increased risk for VTE, but more so when we are giving them COCs. We are increasing the risk factor for developing VTE when we are giving them COCs. And this has been demonstrated by meta-analysis in 3 studies where the mean age was only, and they have demonstrated that there is a definitely increased risk of VTE when compared to controls. We also know that there is an increased risk of obstructive sleep apnea in these women, and that history should be elicited from either the woman or her partner. And then we also should know that obstructive sleep apnea per se contributes to insulin resistance in these women with PCOS. There are many psychological issues, whether it is depression or anxiety. There's a problem about body images, body dissatisfaction, body size, weight, eating disorders and disordered eating. And bulimia is found to be more common, but not anorexia nervosa. And depression and anxiety, depression is found independent of obesity too. And both of them are increased. Another important thing is, which we forget time and again to ask the patient, is their psychosexual function. They report less sexual satisfaction because they consider themselves sexually, they're less self-worth, and when compared to the other women, and it does impact their relationship with their partners. And most of the therapies which we use in PCOS also do contribute to their psychosexual functioning. And as far as NFLD is concerned, there are a lot of liver diseases which come under the umbrella of NFLD. And we have to remember that the androgens which are there associated are the ones which are pro-apoptotic agents. These act on the peripheral cells of the hepatocytes, and they cause a lot of liver destruction. So there can be a huge range from 36 to 70% association of NFLD with PCOS. Coming to cancers, there are moderate quality data which supports the finding of association of 2.89-fold increase in endometrial hyperplasias and malignancies, more so the type 1 endometrial cancers, there, especially in women who are having oligo or amenorrhea. But there is no association found with breast or ovarian cancer, and so surveillance is not required for that. And transgenerational effects are seen. We all have heard about how the daughters can be affected. It is basically the intrauterine maternal androgen exposure which changes the epigenetics, which in turn alters the genes and leads to whether it continues only to the one generation or further into the next 3 generations is being evaluated right now. So we do have limitations. We do not know whether the CVD risk factors are directly linked to PCOS or because of the associated risk factors. And most of these risks are independent of BMI or not. And do the risk factors in adolescent and reproductive age affect the postmenopausal women? And what are the optimal screening tests? So many queries are still pending. And already Dr. Suvarna has projected this slide where the metabolic risk in adolescent PCOS as and when necessary should be evaluated and predicted, where we can make an early change in their lives and bring down the long-term consequences. So the American Heart Association has given us this guidelines to some extent. So whenever there's a woman is obese, her weight, height have to be monitored every 6 to 12 months. If you're suspecting IGT or type 2 diabetes, all women should undergo a fasting glucose or HbA1c, even in low risk. If it is high risk, they should undergo a OGTT. And depending upon what the results come, the frequency, dyslipidemia should be done if for all women who are above age 20 and for young who are at high risk. And the repeat measurement should be done once in 4 to 6 years, depending upon the associated risk factors. Hypertension, check the blood pressure at every visit, simple. There is something known as subclinical atherosclerosis, where we have to look at the carotid artery intima media thickness and the arterial flow mediated dilation, or the calcium scores, coronary artery calcium scores, which help us to identify these women who are in the subclinical phase and where we can do something to them before they go into the active CVD. The health-related quality of life can be estimated by doing the polycystic ovarian syndrome questionnaire, which has 26 determinants, and you can add it to that is the modified one, which also adds acne to it. And you also can do a screening for OSA by the Berlin questionnaire, and by first of all take history, and if your history is suggestive, go ahead with the questionnaire and go ahead for the appropriate treatment. A transvaginal ultrasound, where we can do endometrial surveillance. The history itself is very, very important. And in PCOS, an endometrial thickness of less than 7 mm is not much associated with hyperplasia. So, psychological issues, is it a time?
Yes, ma'am. I think, yeah.
Just finish in 1 minute. Yes. So it's for the psychological issues, we have the sexual function index or the SX, and any negative body imaging should be done appropriately, and for the eating disorder should be evaluated. And for reduction of risk, counseling, exercise, weight control, and also although metformin there has been a lot of studies, there is no evidence in favor of it. And guidelines although recommend starting metformin in those patients who are having either diabetes or impaired glucose tolerance. And when you're giving COCs, remember the risk of VTE and give the lowest possible dose, treat hypertension. lipid lowering treatment only by the specialists, and CPAP when there is an OSA. And for endometrial hyperplasia, I don't think all of us know, I think I will skip this slide. And anxiety, depression as per the requirement by a specialist, bariatric surgery whenever it is indicated. And I would like to say that long-term disease risks in polycystic ovarian syndrome are many, and they may be mostly independent of obesity. So let's not be only thinking of obesity as a causative factor, and think we have to think beyond that. And I would like to thank you all very much for your patient listening, and thank the chairpersons for being there with me. Thank you.
That was an excellent talk, Krishna Kumari. You had put everything in the nutshell. So all we know is that the non-communicable disease, the big umbrella of non-communicable disease, these patients of PCOD are at risk, and it is within us to identify this at an early age and try to guide them so that these complications at their later age can be prevented or avoided to a certain extent. Thank you so much.
Thank you. For the next talk, I invite Dr. Dwarkanath, sir. Can you project sir's slide? So, Dr. Dwarkanath is the president of Tumkur Obstetrics and Gynec Society in Karnataka. He has been is professor and HOD of Department of OB-GYN, Sri Siddhartha Medical College, Tumkur, and he has teaching experience of more than 20 years. And his field of interest is high-risk obstetrics, laparoscopy, and infertility. I welcome you, sir. Kindly introduce our next speaker, Dr. Kalyan Barmade.
Thank you, madam. Dr. Kalyan Barmade is a chairperson, Public Awareness Committee, FOGSI. Sir is a treasurer of Indian Association of Gynecologic Endoscopists. Sir is a convener, Dr. Kalyan Barmade is a convener, Mission Save the Uterus, FOGSI 2019-22. He is also an executive member of MSR and is a zonal coordinator of Association of Mumbai Obstetrics and Gynecology, Maharashtra Obstetrics and Gynecological Societies. Welcome you, sir, to give the talk on endoscopy, endocrinology in PCOS.
Thank you, Dr. Dwarkanath, sir, for such a nice introduction. My topic is reproductive endocrinology in PCOS. At the outset, I'd like to thank Team FOGSI for giving me this opportunity, especially Dr. Kiranmai and Dr. M. Krishna Kumari, madam. So when you talk of reproductive endocrinology in PCOS, PCOS is the most common endocrinopathy among reproductive age women and is typically present during adolescence. Recognizing adolescents at risk for PCOS and taking the appropriate steps to reduce circulating androgen levels is critical in reducing the clinical symptomatology of this disorder, the development of adulthood infertility, diabetes, and metabolic syndrome, what Dr. M. Krishna Kumari was talking about. The major features are excessive hair growth, menstrual irregularities, that is anovulation, polycystic ovaries. This triad of symptom is commonly accompanied by obesity, insulin resistance, and infertility. So women with PCOS are also at increased risk of diabetes mellitus, endometrial carcinoma, and cardiovascular disease, which my previous speaker has elaborated. So whenever there is high androgen, polycystic ovaries, and irregular periods, it is a major clinical features of PCOS. Notable reproductive metabolic abnormalities include increased pituitary hormone, that is LH secretion, incomplete maturation of ovarian follicle development, insulin resistance with compensatory hyperinsulinemia. The symptoms of PCOS usually emerge at or soon after the puberty, which may in some cases lead to failure of diagnosis and potentially to a delay in the initiation of the treatment, which is very important part. So inappropriate gonadotropin secretion, there is increased concentration of serum LH are accompanied by an increase in the pulse frequency and amplitude, which are significantly greater than those of normal controls. Because the onset of PCOS commonly can be traced to the events of puberty, this disorder may involve the alteration of regulatory factors or processes that initiate gonadal function during puberty. In childhood, the activity of hypothalamo-gonadotrophic releasing hormone appears to be suppressed by a central mechanism that has not yet been defined. In Tanner stage 1 girls, gonadotropin secretion is minimal and occasional LH pulses may be observed during the sleep. With the onset of puberty, there is an initial rise in the serum FSH followed by increase in LH at mid-pubertal development, but the increments in GnRH release are accompanied by noticeable increase in LH pulse frequency that appears to achieve adult patterns by Tanner's stage 4 to stage 5. That means puberty is completed. So the recent studies have indicated that the excess androgen production may have profound influence on LH pulse frequency in the women with PCOS. The theory of prenatal origin, which says SCH or LH ratio may act on the fetal ovary and maternal ovaries to cause hyperandrogenism, which may cause prenatal or prepubertal hyperandrogenism. The central fat, which gene regulation, insulin secretion, insulin action, and adipocyte differentiation can cause increase in the insulin resistance and anovulation. So in normal ovaries, what happens in a fertile female, a single follicle matures and undergoes ovulation from a pool of primordial follicle present in the ovaries since birth. The rate at which primordial follicles are selected for growth is strictly controlled in order to maintain ovarian reserve and ensure fertility is intact. But when you go to the PCOS, an imbalance between the androgen, AMH and FSH cause a halt at the follicular growth. So AMH is produced by the ovarian granulosa cell and is important in preventing primordial follicles from transitioning into primary follicles. The characteristic of PCOS is due to large number of primordial follicle growing and undergoing subsequent growth arrest and not forming the primary follicles. So high LH to FSH ratio, high LH levels are required for androgen synthesis by ovarian theca cells. High LH combined with low FSH levels and decreased estradiol synthesis through the conversion of androgen results in anovulation due to absence of a dominant follicle in PCOS. When you see into this picture, the normal cycle and down is the anovulatory cycle. In a normal cycle, only the single follicle, that is dominant follicle, respond to LH when it reaches 10 millimeter diameter. But in PCOS, the response to LH occurs inappropriately in smaller follicles, and many antral follicles reach terminal differentiation before the time itself, producing a greater quality of steroid and inhibin B that exerts negative feedback on FSH production. The second thing important is hyperinsulinemia, which the next speaker is going to talk. But I like to, whenever there is a reproductive endocrinology, we can't forget insulin resistance. So it is another important component of PCOS. It results from inadequate tissue utilization of insulin for glucose metabolism. Although the exact mechanism are yet to be elucidated, genetic and intra and extrauterine factors and adaptation to consumption of high energy food items are considered to be the factors causing insulin resistance in PCOS. Puberty is also thought to have a major effect of insulin resistance. During puberty, there may be a temporary increase in the insulin levels and insulin resistance. Subsequent elevation of IGF and growth hormone level means that more amino acids are available for growth. But during puberty, only glucose metabolism is affected by insulin resistance while protein metabolism is spared. So in PCOS, insulin resistance affects the liver, adipose tissue, skeletal muscle. However, the steroidogenic ovaries and adrenal glands remain sensitive to the actions of insulin. Here you can see hyperinsulinemia stimulates directly cytochrome P450 enzyme in the ovary or indirectly through the action of LH or IGF-1 causing hyperandrogenism. Another effect is elevated levels of free androgen. Women with PCOS often have elevated serum insulin and insulin resistance regardless of androgen concentration and their level of adiposity. Ovarian folliculogenesis is regulated by a delicate balance between the extra and intra-ovarian factors, and the equilibrium may alter and compromise follicular development and formation of mature oocytes that may lead to infertility in the cases of PCOS. So extra-ovarian factors like decreased FSH, increased LH, hyperandrogenism, hyperinsulinemia, and intra-ovarian factors like growth factors, cytokines, homocysteine, leptin, oxidative state, which causes follicular alteration and oocyte abnormalities, which can cause poor embryo quality in the PCOS. A high percentage of women with PCOS has elevated LH to FSH ratio, presumably due to high level of LH rather than reduced production of FSH. GnRH stimulation causes excessive LH production in these women. This condition may be determined by a higher frequency or amplitude of GnRH. It is not yet clear whether alteration in the hypothalamo-pituitary axis in PCOS is primary or secondary to the alteration in the steroid hormone secretions. The role of FSH is always to recruit ovarian follicle and stimulate their growth. 2 to 5 millimeter follicles are most sensitive to FSH, whereas larger acquire aromatase activity and may increase estradiol level and inhibin B, reducing the levels of FSH in late follicular stage. On the other hand, in PCOS patient, having LH and FSH concentration higher and lower FSH than normal accumulate antral follicles that differentiate early and undergo premature growth arrest, and hypersecretion of LH in these women may promote early luteinization of granulosa cell and contribute to early growth arrest of antral follicle. That is why LH may also activate premature meiotic process that damage oocyte quality and contribute to the formation of embryonic aneuploidies. When you see this ovarian and extra-ovarian hyperandrogenism, relative inhibition of 1720 lyase activity with respect to 17 hydroxylase has been found in women with PCOS. This leads to increase in 17 OHP to android ratio and reduction of aromatase activity, the enzyme of granulosa cell that converts androgens to estrogens. That is why low aromatase activity has also been demonstrated in women with PCOS. Aromatase is a granulosa cell enzyme that converts androgens to estrogens. So it may be partly responsible for hyperandrogenism in this syndrome. What are the other factors which can play a role? I'm just like to enumerate few intra and extra ovarian factors like epidermal growth factor, which plays important role in regulation of cell growth as well as proliferation and differentiation through its receptor EGFR. In PCOS, EGF may inhibit granulosa cell estrogen synthesis, which is translated into arrest of follicular growth. IGF, these IGF levels in PCOS women are elevated than the normal, whereas IGF-BP1 are lower in PCOS patients, causing arrest of the follicular growth. The most important for us is, yes, last 1 minute, is AMH, is a homodynamic glycoprotein that inhibits the development of Mullerian ducts in male embryos. It plays important role because high serum levels directly correlated with increase in testosterone and or LH concentration in women with PCOS, as well as with altered oocyte maturation and low embryo quality. That is why serum AMH, predominantly synthesized by small antral follicle, ranges between 2 to 9 millimeter diameter and is very important test when you consider with the antral follicle count. VEGF and others like interleukin, TNF alpha or FOGSI can be there. So to summarize, diagnostic workup includes hormonal evaluation of androgen levels, clinical evaluation of hirsutism, ultrasound evaluation of antral follicles and ovarian volume. Also, insulin resistance can be measured, but the most important remains 3D ultrasound and role of anti-AMH. That is very important. PCOS is a multifaceted disease which commonly affects fertility. Management for obese women is weight reduction, that is 5 to 10%. First line therapy should be always aromatase inhibitor like letrozole, then CC, and second line should be gonadotrophins, laparoscopic drilling or IVF. prevention of OHSS should be the key whenever you are treating the PCOS cases. Thank you so much for patient listening.
Thank you, sir. Thank you so much. Dwarkanath, sir, can you conclude this?
Hello.
Yes, sir.
Yeah, thank you, Kalyan sir. It was really indeed a very excellent talk to covering all the aspects of PCOS, especially what is more elusive, that is the endocrinology. Thank you very much.
Thank you so much, sir. That was crystal clear and very crisp and in time. Thank you all the faculty for being in time and obliging us. Thank you so much. For the next talk, I would like to invite Dr. Narendra Gajjar, sir, who is a very senior member and sir is from Ahmedabad and he is practicing gynecologist at Ashirwad Hospital and Akash IVF Center, Chikli since 37 years. He has been past president of Society of Gujarat Obstetrics and Gynecologists 95 to 96. At present, he is president of Navsari Gynec Society. He has participated in many national and state level conferences as faculty and demonstrated NDVH in many surgical workshops, including AICOG, SOGOG, and Urogynec conferences. Wide experience of managing complicated obstetric cases, organizing chairperson of SOGOG 95 2012, midterm SOGOG, and West Zone FOGSI Conference 2021. Welcome you, sir, and it's a pleasure to have you. I request you to introduce our next speaker, Dr. Ritu, who would go ahead with her talk. Thank you.
Thank you, madam. Thank you for nice introduction. And at the outset, I would like to thank Dr. Kiranmai and Dr. Krishna Kumari. And it's a pleasure for me to introduce Dr. Ritu Khanna. She's in organizational position, chairperson FOGSI, Food and Medico Surgical Equipment Committee 2021 to 24, Secretary of Society of Fetal Medicine, UP Chapter 21-24, Joint Treasurer, Indian Fertility Society, working on exclusively single embryo transfer, and she has been credited to so many awards and she has published many papers. May I welcome Dr. Ritu Khanna to give her speech.
Thank you so much, Dr. Narendra sir, for those very, very kind words. And my gratitude to Dr. Shanta Kumari madam, Dr. Madhuri Patel ma'am, Dr. Fesi Lewis sir, Dr. Krishna Kumari ma'am, and Dr. Kiranmai. And also my respectful regards to Dr. Chandravati madam, Dr. Usha Sharma madam, and also Dr. Nandita Palchetkar madam. To start my presentation, could I share my screen, please? You have to stop the share screen to let me share my screen. Yeah. So my topic is steering with insulin resistance. Now, what does the insulin do into our body? It really moves the glucose into the muscle. It suppresses gluconeogenesis and stimulates lipogenesis at the adipose tissue. How does the body compensate? It produces insulin, which is going to sense the glucose, even the small rise, which is going to result into the output of insulin to restore this glucose to normal. So when there is a decreased ability of insulin to stimulate glucose transport into the cells, or a decreased glucose response to the given amount of insulin, and that's called as an insulin resistance. We are having a food, the glucose comes into the blood, the pancreas secretes insulin, but when the cells are insulin resistant, the cells do not have this energy, and so they start feeling hungry. We eat more, we produce more glucose, so the more insulin, and thereby hyperinsulinemia. So now this combined insulin resistance and hyperinsulinemia modulates the gonadotrophin secretion. There is a rapid GnRH pulse, and there is an increase in the LH. And all this is going to lead to an androgen production from the adrenal and the ovaries, so a hyperandrogenemia. The hyperinsulinemia, there's unutilized glucose, there is a fat deposition, and therefore the obesity and a pre-inflammatory condition. Why are we worried of this obesity and this visceral fat? Because it correlates with the total androgen level. And this adipose tissue mimics the endocrine. So there's an increased leptin, there's a decrease in the adiponectin. So reduce androgen to estrogen conversion and reduce insulin sensitivity. Not only this, the endocrine modulator for the two major hormone conversions, androgen to estrogen and cortisol to cortisone. So this hyperinsulinemia and hyperandrogenism going to stimulate the theca cells, stimulate the pituitary, and look at what is happening. It's really going to impair the reproductive functions. But the story doesn't end here. Obesity is chronic inflammation. It causes oxidative stress and adverse pregnancy outcomes. So we have gestational diabetes and we have pregnancy-induced hypertension. So insulin resistance is a critical driver of this hyperandrogenism in PCOS. It's present in 80% of the obese women and in 30 to 40% of the lean as well. So suggesting that the defect is intrinsic to the PCOS. But why only these PCOS? What is so that they become insulin resistant? It is attributable to a post-binding defect in the receptor, insulin receptor signaling. Binding to the insulin receptor should result in a tyrosine phosphorylation before stimulating the insulin action. And now if however, a serine phosphorylation occurs, the insulin action is inhibited by decreasing its kinase activity. And so we are worried it's going to lead to a long-term sequelae, obesity, diabetes, heart disease, and so on. And it's also been found that 30 to 35% of these patients of PCOS have an impaired glucose tolerance. And the PCOS carries an inherent risk of insulin resistance. So therefore, they should be screened regardless of a BMI or a degree of obesity. Insulin testing, there's really no accurate way of measuring this insulin resistance. But alternatively, a standard oral glucose tolerance test, that is a measurement of a glucose and insulin levels, may provide an accurate estimation of the insulin resistance, while at the same time providing the accurate information about the tolerance. Why is it important? Because insulin resistance is recognized as a major risk factor for type 2 diabetes. So a fasting glucose insulin ratio has been proposed as a very rapid and an easy screening test. And if these obese adult women have a fasting glucose insulin ratio less than 4.5, it suggests insulin resistance. But is there any signs of seeing this insulin resistance in our clinics as well? Yes, truncal obesity, a metabolic syndrome. You find the small skin tags that you see into this picture, acanthosis nigrans, a sleep apnea, psychological disorders, or the hirsutism, acne, alopecia, and ovulation and all are the hyperandrogenic manifestations which give us a clue. So the options now for treating this insulin resistance are: the first is a lifestyle modification, the exercise, the diet, and the weight loss. And then comes the insulin sensitizers. And last on the list is the bariatric surgery. So the first line strategy, reduction in the insulin resistance for amelioration, is to decrease the testosterone, the ovulatory function. The primary goal is the lifestyle changes. That's a diet and the physical exercise, and along with the weight loss. So what is this lifestyle modification? It's a program encompassing a caloric restriction and also an increase in the formal exercise. What do we mean? That means we need to take a regular physical exercise and also a minimum of 30 minutes of moderately intense exercise, at least 3 days per week. And with this, we need a behavioral modification when we are attempting to do it. And what's a diet? The calorie needs to come down 1,000 to 1,200 kilocalories and an average loss of 10% over 6 months. So the most important factor for weight loss is the caloric restriction. And it does not seem to matter whatever is the dietary composition. But yes, there have been studies in obese individuals that the decrease in weight loss at 6 months is much better as compared to when you're taking both for a 12 months, comparing them with the 12 months loss. But like all chronic conditions, this lifestyle changes have to be continued and the women should not regain this weight. So carbohydrates with a low glycemic index, with a high fiber content, allowing this glucose to be retained within the lumen of the gut for a slower release. And the insulin excursions we know after a single large meal is much greater than after small meals, so they should be taking smaller meals. So targeted weight loss and subsequently a prevention of weight loss, which includes a dietary restriction and the exercise. So this is the first line therapy. But when you're doing this, there's so many behavioral problems, abnormal eating patterns, self-confidence is damaged, and so on. So you really need a psychological intervention. If this doesn't work, then you move on to the next is the insulin sensitizers, the anti-diabetic obesity drugs, and the bariatric. Now, the insulin sensitizers favor beneficial effects of lowering insulin sensitivity, hyperandrogenemia, and so on. The metformin, the first choice, reduces the basal levels of the free fatty acids, which has role in reducing the glucose disposal in the skeletal muscles, and therefore the insulin sensitivity is taken care of. Otherwise, we have the rosiglitazone and the poiglitazone, which lowers the fasting plasma glucose and insulin and the C-peptide when administered in patients of diabetes type 2. And this is a list of the other insulin sensitizers, and I think we're using the D-chiroinositol too. A word about metformin, that there's no strong evidence regarding the long-term benefits for the use of sensitizing in women who do not have a diabetes and metformin, but has been shown to have a beneficial short-term effect on insulin resistance and other cardiovascular risk markers in PCOS, even without type 2 diabetes. And then comes the role of anti-obesity. Yes, it reduces a small weight reduction and improves the biochemical hyperandrogenism, but without changing the glucose insulin homeostasis. And last is the bariatric surgery should be performed only after the standard weight loss strategies that have failed in the women with PCOS, and those women only who have a BMI of 40 kgs per meter square or a BMI of 35 or more together with a high-risk obesity-related condition. So it stands as a last option. Therefore, every step counts, and though every step is very, very challenging, don't underestimate small steps. It's only a small step which gets you so closer and closer to where you want to be tomorrow to beat this insulin resistance. So thank you so much for a very patient hearing and success series and making us move with a high speed and steering with insulin resistance. Thank you so much.
20 seconds to go, Dr. Ritu. Thank you. Narendra sir, your comment.
Yeah. Really, Dr. Ritu, it is a wonderful lecture. Within 10 minutes, it is very difficult to cover insulin resistance, but you cover almost all topics, including starting from effects of serine phosphorylation to cellular level, then hyperinsulinemia, then hyperandrogenemia, and then reduce aromatization, and everything you have covered. You have given very important messages that all PCOS should be screened regardless of BMI. You have very nicely given us important information about lifestyle modification, insulin sensitizers, anti-obesity drugs, and bariatric surgery, of course. Very well covered topic. Thank you.
Thank you so much, sir.
Thank you, sir, for chairing this talk, and thank you, Ritu. That was excellent. Next, we move on to yet another scintillating talk from Dr. Jyoti Malik. Do we have Dr. Vidyadhar Bangal, sir? Yeah. Can I have Sir's CV? Sir is from Loni. He's professor and head. We are having a lot of teachers today, professors. So lucky to have you all today with us in the DBVP Rural Medical College, Pravara Institute of Medical Sciences, Loni, Ahmednagar, Maharashtra. With a teaching experience of 32 years, he has been a postgraduate teacher, examiner, PhD guide, and member of Women's Task Force International Organization with Network Towards Unity for Research with 153 research publications, Google Scholar citations of 909, H index 14, I10 index 28. You are a true teacher, sir. Then member of editorial board on 4 international journals, peer reviewer of 6 international journals, including BMJ Open Quality. Areas of special interest: high-risk pregnancy, obstetric emergencies, medical education technology, healthcare quality, membership of many professional bodies, and co-chairman Board of Studies of Reproductive Child and Health, PIMS. Thank you so much, sir. I request you to introduce Dr. Jyoti Malik for her talk.
Good evening, everyone. At the outset, I thank Kiranmai and Krishna Kumari Madam for inviting me to be part of this very important webinar on PCOS. I'm privileged to introduce Dr. Jyoti Malik, and she will be delivering a very important lecture on stimulation protocols, another important area when we talk about PCOS. Dr. Jyoti Malik she is a medical superintendent.
Thank you for the introduction. I think we
Yeah,
can say
please go ahead.
You can sort of sum up and give your expert comments at the end of talk. That
please
wonderful.
Go ahead, madam. Already we are late, so please go ahead.
Yes, sir. I think we can see the screen. So I'm the fifth batsman in order, and what innings! And thank you so much in regards, Dr. Shanta ma'am, Dr. Madhuri ma'am, Dr. Kiran Mai ma'am, Dr. Krishna Kumari ma'am, and all the guests of honor, Dr. Usha ma'am, and Dr. Chandra ma'am, Dr. Nandita ma'am, everybody. I mean, the whole show has been meticulously planned, and all the speakers excellent. And my responsibility is now to know and understand whether the stimulation protocols are they different in PCOS. Yeah, so in PCOS, we have been hearing about the ovulatory disorders, and 75% of these ovulatory disorders present in these cases of PCO. And I would be talking from the International Evidence-Based Guidelines 2018. So no confusion now in diagnosing. My speakers have already cleared it out. We follow the Rotterdam criteria. But why is it different? Why? Because we have 6 times the density of preantral follicles as compared to the normal ovaries. We have a large cohort of small follicles, but they're still capable of responding to the exogenous gonadotropins or FSH, whatever we give. And because of this sensitivity, there could be an explosive many early antral follicles, which are not only many, but also they augment the follicular FSH receptor expression. So I would be dividing my talk into 2, as Dr. Paiser was saying, it is like walking, it is like a cake walk. Okay, in IVF, yes, most of them, but still we can have problems. And IUI, definitely we don't have such good results there. So what do we do? I would be dividing in IUI and IVF. So first, make a proper diagnosis. And as far as possible, if we can avoid IVF and do other options, we can have these multiple choices. We have weight loss, clomiphene, aromatase inhibitors, insulin lowering medications, gonadotropins, laparoscopic drilling. So one by one, weight loss, a steady decrease is very important, and it reduces hyperinsulinemia and insulin resistance, and 5% loss is good enough. Now, first line of treatment. So what the guidelines tell us now is that letrozole should be the first line of pharmacological treatment in these PCOS, unless letrozole is not available or it is not permitted. So letrozole first. And what are the various protocols that we follow? One can give it 2.5 mg twice a day for 5 days from day 2 of the cycle. Or one can use a step-up protocol. That means 1, 2, 3, and 4 tablets from day 2 to 5. That means on day 1, we give 2 tablets. Day 2, we give on day 1, we give single tablet. On day 2, we give 2. On day 3, we give 3. And on day 4, we give 4 tablets. So this is how we step up the protocol. Now, otherwise also what we can do is, if it is a latrose resistance, not only clomiphene resistance, we do also have letrozole resistance. So we can increase per cycle the amount of letrozole. Or we can have an extended protocol where we give 2.5 right from day 1 to 10. Or it could be a single dose, or we can use it along with the antagonists. Now, clomiphene, we have all been using it for so many years, and we are all trained and we are all comfortable using it. But the problem is that half of the cases do not respond. So we normally start with 100 mg because we can get a good ovulation rate with 100 mg and a good conception rate. But as we increase the dose, if we make it 150 or 200, we see that the ovulation decreases and the anti-estrogenic effect, that means the side effects, start increasing. So these CC resistant are the women who are obese, who are insulin resistant, who have high androgen, who have high LH, or who have high AMH. So whenever we have the CC resistance, whenever we have the CC failures, that means no conception after 6 cycles, or because of the clomiphene, we have a thin endometrium aligning less than 7, we move on to aromatase. That was the dictum before, but now we start with aromatase. So we all understand how the mode of their action is. So clomiphene is causing these blockage of the estrogen receptors, whereas the letrozole is affecting the aromatase inhibition. So here, because of their mode of action, we get in clomiphene, we get multifollicular development, whereas in letrozole, we get monofollicular development. And the side effects, because of the anti-estrogen effect, clomiphene will lead on to hot flashes, nausea, breast discomfort, visual disturbances, ovarian cysts, and multiple pregnancies and a bit of hyperstimulation. Whereas in letrozole, we get a lot of fatigue and dizziness. Now, should we be using metformin? The guidelines say that yes, in CC resistant, always add metformin to improve our results. So should we be using, now once we've used CC or letrozole in combination with metformin, and if it fails, what is the second line of drugs? So we have gonadotrophins, and can we use gonadotrophins as a first line? Our evidence says gonadotrophins as the second line in PCOS who have failed first line of oral ovulation induction treatment. Now, as first line, definitely we can use, provided we have the expertise to use it, provided we have an intensive ultrasound monitoring, provided we have counseled the lady that the cost is involved, we have the gonadotrophins available, and we should always be using a low dose gonadotrophin protocol so that we reduce the risks and implications of the multiple pregnancies. So chronic low dose is something which is very popular for these PCOS women, where we start with a very, very low dose. We start with as low as something like 50 to 75, or we can even start only with 75, give it for a long period, give it for 10 to 14 days, then do the follicular monitoring, look for the follicle size. If it is still more around 10 mm, we gradually increase the dose by only half a ampule, that is around 25 to 37.5. Again, wait for a week and then keep on watching. If the dominant follicle then reaches 18, we give the trigger. But we cancel the cycle if we get more than 3 follicles, more than 15 mm, because every time we want to be safe, we don't want the patient to land up into hyperstimulation, and we don't want multiple pregnancies. So once there is resistance, either with CC or letrozole, can we straight away go to laparoscopic ovarian drilling? Can it be the first alternative? Yes. In certain cases, yes, where we are doing where it could be where we are doing other options for laparoscopy, like if there are other infertility factors, if we have endometriosis or anything, and we need to do laparoscopy, there we can go in for LOD with the prior consent, prior explanation, prior counseling. Or we can also go next to LOD after the gonadotrophins have failed. Now, what is the role of laparoscopic ovarian surgery? it can be taken as the first line, as I told you, according to the evidence, if it is indicated for any other reason in these women. But we have to be having the expertise. It is a surgical procedure. There could be risk in obese. There could be risk in very thin and lean PCOS. It can lead on to adhesions. And if we are over enthusiastic, we can even damage rather than helping the lady out by causing diminished ovarian reserve. So we have to be careful if we are doing the laparoscopic drilling. So this is how we fall. We can start with clomiphene or letrozole, 4 to 6 cycles. Add metformin if there is no result. If it is failure, CC failure or resistance, go on to gonadotrophins and then either select what we wish to do, whether we wish to go on the third line as IVF or as LOD. So here we see the pregnancy rates in letrozole and FSH as good in letrozole and FSH, but here the multiple pregnancy rate is quite high when we use the gonadotrophins. So as in all these cases, we are carrying out IUI along with this because we want to increase the number of eggs by doing this ovulation induction and carrying out IUI, because only IUI, the pregnancy rate is 4%, but when we add clomiphene, it becomes twice, that is 8%. When we use only gonadotrophins, it is around 8%, but when we add gonadotrophins and IUI, it becomes double. It becomes somewhere around 16-18%. So that is the highest thing that we can do with the IUI. Now, IVF. Yes, ma'am. Another 5 minutes. So IVF is the third line ovulation induction, but we have to counsel about cost, the risk of OHS, and the options to reduce it. So what are the problems? We can have excessive response, low fertilization, high immature oocytes, reduced cleavage, low implantation, high miscarriage. And there was this meta-analysis which said that you could achieve fuller pregnancy and life rates in these women. Now, the number of oocytes in these women is slightly higher, but the quality of oocyte was not statistically different according to this research article, which is very, very recent. Now, there is difference in fertilization because of the immaturity of the oocyte, because the effect on the oocyte quality and the miscarriage rates are higher, and not only that, preterm delivery rates are higher. And this is all because of hyperinsulinemia, high LH. So how do we overcome these problems? By mild stimulation, by pre-treatment, by using antagonist, by using agonist trigger. And in this paper, the pregnancy rate was higher when we use an antag-mild protocol. So this is how we see that the oocytes are more, the embryos are more when we are using a mild protocol, and the OHSS is less. So how do we schedule this antagonist cycle? We can use any of these pre-treatments, OCP, estradiol, antagonist, and but we have to give a washout period of at least 5 days in these cases. Antag there is no doubt left that we have to use antags. The evidence says that the antag reduces the duration of stimulation, the total dose of gonadotrophins required, and the incidence of hyperstimulation. Can we use metformin as adjunct? Yes, definitely, in both antag as well as agonists. Should we be using any choice of FSH? No, nothing. Urinary or recombinant, anything can be used. Should we add LH? Not routinely. What should be the trigger? If we are giving HCG, lowest dose, otherwise agonist trigger and a freeze-all policy in all these women. Now, the antagonist, what it does is reduces the OHSS. And should we freeze all? Yes, only if there is increase in the pre-ovulatory progesterone. Otherwise, there is no need. And we should be using high stimulation protocols. So elective single embryo transfer should be done, and we should have a robust embryo cryopreservation. In these, IVM may be tried. So to conclude, the antag appears to be attractive option. We should always aim to reduce our OHSS have OSHS free clinics, use soft stimulation, use an agonist trigger, and always do a single embryo transfer. So thank you so much, sir. And thank you, FOGSI and Kiranmai ma'am and all the team.
Thank you, Dr. Jyoti, and sorry about, but we had to have the 10-minute cutoff. So, yeah, it was an excellent. Dr. Bangal, we can have a quick comment from you, sir.
Thank you, Dr. Jyoti, for really covering this whole topic in the best possible way. You have covered everything in short, and maybe sort of revision for everyone about the various protocols and what are the pros and cons and how we should step up. So it was a very good topic and very well covered. Thank you very much.
Thank you so much, sir, for chairing this session. We move on to the last talk. For this, I invite Dr. Gayatri Rathod, who is President of PUSAD OB-GYN Society, and she's past Secretary and Vice President of PUSAD OB-GYN Society, member of Family Welfare Committee, member of High Risk Pregnancy Committee, and very active in FOGSI and also the Green Plantation Group, lover of environment and plants. Welcome, Dr. Gayatri. Kindly introduce Dr. Ekika Singh for her talk.
Thank you, madam, for your kind words. Good evening, everyone. At the outset, my sincere thanks to Team FOGSI and Dr. Kiranmai madam for the opportunity. It's my pleasure to introduce Dr. Ekika Singh. She is the Executive Member, UP ISAR State Chapter, Assistant Editor, International Journal of Human Reproduction Research and Development, research work on role of progestin primed ovarian stimulation in IVF and ICSI, stimulation protocol and role of platelet-rich PRP in thin endometrium, 15 publications in international and national journals and contributed chapters in books. Her posters and paper presentations in international and national conferences. She is the recipient of best paper presentation. I welcome Dr. Ekika for her talk.
Shriman, stop sharing.
Please unmute.
On the onset, thank you, Dr. Gayatri, and thank you, Team FOGSI, especially Kiranmai madam and Krishna Kumari ma'am for giving me this opportunity. Well, I'm the sixth batsman of the team, and I'll be sharing my there's some net problem.
Dr. Ekika,
yeah.
Any problem with sharing the screen?
Yes. Ma'am, can you see now? Can you see the screen?
No, madam. No.
No. And can you see the screen now?
No.
एकिका पहले अपना प्रेजेंटेशन खोल लो फिर शेयर करो.
Okay. And that's what I did. Just a second, wait.
Don't make it into don't make it into full screen. Just open the PowerPoint.
Okay.
And then share, and then select that. If not working, you may have to restart.
Yeah, I'm not able to see my screen. That's the problem.
Can you send your presentation to
the WhatsApp or the
Or
group?
Yes, ma'am, I can.
Can you put it in the group? Somebody else can do it for you, Dr. Kika?
otherwise you restart also.
Close it. First you close it. Stop sharing.
Okay, ma'am.
You stop sharing. Open your presentation afresh.
Then you go to the Zoom and start sharing.
Ma'am, can I send you my presentation?
Sure, sure.
Press share screen or share content. You press it now. You'll see your presentation. Then you press on the presentation and share.
Sometimes it does give trouble.
Yes, sir. Actually, I have opened my presentation, but I don't know why it's not being.
No, go to share screen. You do first. Press on share screen.
Okay. Okay.
On this Zoom, what you're seeing, no? Share screen, share content. There's a different color in between.
That
Yeah,
green
this
color
green
is
one,
there.
no? Yeah.
Green
I'm doing
color.
it.
Yeah.
Yeah,
You
but
press
yeah. Okay. Now presentation is come.
and then share. Press share down.
Yeah. So now can you see, sir?
Right.
Yes, it is seen.
Now you go to the full screen mode.
Make it a slideshow mode.
Yeah, I'm doing that.
Yeah.
Okay.
Right.
Yeah, great.
Yeah. Thank you. Yeah. Thank you, ma'am. I'm sorry, though I'm being the sixth batsman. I thought of winding up it fine, but it started with a glitch.
Carry
So I'm winding up with the add-ons, the values they add, whether they had to be used or not. So after all the talks and everything which we have heard from my previous speakers, my seniors, I still want to know, do we understand PCOS better now? Well, some of us will say yes, some of us may say maybe, but for me, it's like a black hole. The more you know, there is more to it added on to be known. Why is it so? The pathophysiology is being beautifully explained by my previous speakers. It is not only limited to the uterus and the ovary, it has both the central and the peripheral effects, parade of hormones and the gene expressions and even the enzymes which take place, and then it leads to a metabolic syndrome if not treated on time. So what does PCOS does? It has a huge impact on reproductive, metabolic, cardiovascular and mental health of affected girls and women. What can be done? As it is well said by everyone, it is a multiple organ involvement, so the treatment has to be multidisciplinary, involving every part and every corner. So the goal of the therapy has to be lifestyle plan and support, treatment of hypoandrogenic symptoms, endometrium protection, contraception, fertility, yes, which is very much required, psychological and behavioral support. These girls and ladies do need that, nutrition counseling, metabolic screening and intervention, as been told by rest of my previous speakers. We know there are recommended drugs and they are there in the recommendations and guidelines. Today, I'm here to talk about the new therapeutic approaches, the add-ons, the engines. How do they add value to our treatment or whether they can be used or not? Well, what is the relevance of using vitamin D in PCOS? It is seen that the vitamin D deficiency and insufficiency have been associated with many of the overt and covert symptoms that are prevalent in PCOS. And it is found that the supplementation of vitamin D will help in ovarian dysfunction, hyperandrogenemia, insulin resistance, indices of adiposity, dyslipidemia, risk of diabetes, systemic pro-inflammatory mediators. So vitamin D acts at different levels and does help to improve the state or hormonal value and the symptoms and signs in a patient suffering from PCOS. So these are few points which I have discussed. When it comes to vitamin D and androgen, vitamin D supplementation lead to augmentation of aromatase activity and increases sex hormone binding globulin. There is a factor, a pro-inflammatory factor called advanced glycation end products. These products, they are harmful. They bind to the cell membrane of the follicle and they lead to atresia or maybe having some harmful effect on the follicular growth. So to counteract it, there is a soluble receptor which binds to these aids and then it decoys its effect. So what does vitamin D does? Vitamin D supplementation increases the soluble RAGE levels, which helps to bind age and it decoys and hence prevent the harmful effect of follicular harmful effect on the follicles and help for the proper growth of the follicle. Vitamin D supplementation also reduces pro-inflammatory cytokinins, interferon gamma and TNF-alpha, and increases the level of anti-inflammatory cytokinins such as TGF, interleukin, growth factor 4. What is about insulin resistance? Vitamin D signal via vitamin D receptor enhances the genomic stimulation of insulin receptor messenger RNA, thus helping to improve the sensitivity of insulin and then helping to control hyperinsulinemia. When it comes to lipid metabolism, it reduces circulating level of total serum cholesterol. In adiposity, as well taken up by Dr. Ritu Khanna ma'am, vitamin D also helps to inhibit adipocyte lipid binding protein 2 expression and fat accumulation in pre-adipocytes. So, add-on of vitamin D supplementation, and it is being seen, there are a lot of studies and meta-analysis which have shown that the PCOS patients are vitamin D deficient. In fact, supplementation of vitamin D not only in PCOS, even in general population in females is the need of the hour. Next comes to inositol and PCOS, myoinositol and D-carboinositol, which is most spoken about two drugs, and there are large number of studies which are there on these two drugs. Before starting about use, I just want to have a small brief about the glucose metabolism in normals and how it happens. Insulin binds its receptors from forms a complex called IRS. This IRS stimulates messenger called P113 kinase. This activated kinase activates glucose transport 4. This again helps in transport of glucose and help it for the utilization of energy. So what does inositol does? This inositol activates and produces both the P13 kinase. Thus, it helps in glucose metabolism and regulate glucose levels in the blood. It is seen, there are in studies, it is seen that metformin action is also limited if there is decreased level of inositols, and there are studies which have shown that in PCOS patients, specifically in obese PCOS patient, inositol levels are less. So supplementation of inositol will help in case in having a better glycemic control. So how does it help? Myoinositol, it improves insulin sensitivity and HOMA index. It also reduces total and free testosterone level, which leads to significant improvement of acne and hirsutism. It improves ovulation and gives better clinical pregnancy and live birth rate. There are studies which are done and shown myoinositol, if used with metformin or with CC, improves ovulation and is better and gives better clinical pregnancy in the patients. It also improves oocyte quality and maturation, reduces again both as in told. Dichloroinositol improves several endocrine parameters such as LH, LSFHs, and androstenedione. Reduces hyperandrogenism. For this, its action on androgen levels is more than that of myoinositol, and of course, it improves quality, oocyte quality and maturation. But it is seen that higher level of D-chorioinositol may lead to poor quality oocytes. So a combination of myoinositol and D-chorioinositol counteract PCOS at both systemic and ovary level in the ratio of 40:1. Now what about glucocorticoids? Glucocorticoids have been proposed as a useful adjunct to both clomiphene citrate and gonadotropin ovulation induction in women with PCOS. In follicular phase, it enhances follicular development and ovulation. Dexamethasone reduces ovarian androgen level, improving ovarian function. As it was covered by my previous speakers, that 70 to 80% of androgen production is by the ovary, but then the adrenal gland and rest of the part which do produce androgen are the one where dexamethasone does have an action, and it acts in an inhibitory way and reducing the hyperandrogenism. What about melatonin? Well, melatonin is a anti-inflammatory, antioxidant, and immunomodulatory agent. Besides on skin, it is also found in reproductive organ, including follicular cell, oocyte, cytotrophoblasts are there. Melatonin promotes follicular maturation or ovulation through the protection of follicles against oxidative stress and their rescue from atresia. It shows a protective effect on corpus luteum against ROS by its antioxidant effect. There are studies which have shown it reduces body weight, BMI, by reducing the total fat. It also can adjust the hypothalamic axis by inhibiting the release of hormones such as FHS, which reduces cystic follicles. Melatonin can also regulate the synthesis of GnRH through its receptors in the granulosa luteal cells via inhibiting GnRH receptors expression. Next come N-acetylcysteine in PCOS. It's a mucolytic agent. Again, it is seen to improve insulin sensitivity and decrease androgen level, can improve ovulation and pregnancy rate. It may have some beneficial effect on the endometrial thickness. Chromium polynicotinamide in PCOS, it's a metal. It's active compound of the glucose tolerance factor, which is responsible for binding insulin to the cell membranes receptor site, improves insulin sensitivity, stimulates the metabolism of sugar, fat, and cholesterol. Orlistat in PCOS, as we know, PCOS and obesity goes hand in hand and has been covered by Dr. Ritu ma'am. Orlistat used in obese patient leads to an improvement in insulin resistance. Same goes for ma'am, just 2 minutes. Adiponectin in PCOS, again, it helps to improve the state. What about statins? There is a contradictory evidence about the use of statins in PCOS. They have shown improvement in hyperandrogenism, but there is associated impairment of
I request you to
yes, ma'am. Bariatric surgery has been covered by madam. This is non-pharmacological use. So just the international guidelines, recommendation, anti-obesity medication, in addition to lifestyle, could be considered for management of obesity. Poorly tolerated in the presence of other effective anti-androgen can be also given. And inositol should currently be kept as a experimental therapy. They are not still approved by NICE guideline and ASRM. So in nutshell, the therapeutic plan should be tailored to the patient phenotype, complaints, and respiratory desire. Although mechanism of action have been proposed, justification of the use of adjuvant therapy is usually empirical and is based on physician personal view. So to end with, I think we should demand evidence, but we have to think critically. When we treat a PCOS patient, it's a multiple organ involvement. So with our add-ons, if there is a symptom relief, they should be added. Thank you very much. Thank you, ma'am, for giving me.
Thank you so much, Dr. Ekika, as we are really running late. Thank you for that crisp talk. I will move on to the next session, that is panel discussion. Can I have the series of the moderators today? We have Dr. Pratik Tambe and Dr. Aarti Luthra, who are very well known to FOGSians. Dr. Pratik has so many on his slide as CVs. It will take quite some time. We know that he was the past chair FOGSI Endocrinology Committee, presently chair AMOX Endocrinology Committee, is a governing council member, managing council member, is lots and lots of awards to his credit. Welcome, Dr. Pratik. Can we go
Thank
to
you,
Dr.
ma'am, for inviting me.
Dr. Aarti Luthra is president of Dehradun Society, OB/GYN Society, and joint secretary UP IAGE. She's very well known for her interest in infertility, endoscopic surgery, and high-risk pregnancy. Again, lot of awards: champion of ISAR, outstanding daughter of Uttarakhand, and prize-winning competitive video at JessiCon, etc. Thank you, Dr. Aarti. Can we have the panelists? We have Dr. Sampath Madam joining us as the expert panelist. We'll request Madam also to take part in the interaction. Madam is FOGSI Vice President elect 2022, and she's so well known for her work in the as an Adolescent Health Committee Chair, and extremely hardworking, sincere, and most humble. And she's an example for me personally. Thank you, ma'am, for joining. Dr. Mandakini ma'am had to go leave because of an emergency. So we have our emergency replacement, Dr. Raki Singh, who is the present endocrinology committee chairperson, to join us. And again, we have eminent panelists, Dr. Achla Batra madam, a very senior member, professor, and president of AOGD, joining us as one of the senior panelists. Can we have the next slide? Dr. Vidhu Modgil, who is presently busy organizing the North Zone Yuva FOGSI. She is presently Ludhiana president and member of so many associations and a lot of awards, and with interest in infertility and again high-risk obstetrics. Thank you, ma'am, for joining us. Can I have the next slide? Dr. Padmaja, I'm not able to see her, but welcome you if you join. She's president of the Rajamandri Society, again with interest in infertility, gynec endoscopy. And next, Dr. Archana also could not join us because he had to leave for an emergency. Dr. Mahesh Korigal sir is from Bangalore. Again, he's in the Kasoga. He's in charge of this same endocrinology committee, as I know. Has a lot of organizational positions, and he's a teacher, former assistant professor, teacher fellowship program in reproductive medicine. Yeah, that's what he's in charge of in Kasoga, Karnataka Society, and with a lot of academic excellence. Welcome you, sir. Dr. Mega also could not join us because of fever. Over to you, Dr. Dinesh Pathak. He's from Firozpur, Punjab. He's presently the secretary of the Firozpur OB-GYN Society, and he received CMD award twice for excellent work in Northern Railways, and he's presently working as senior divisional medical officer in Indian Railways. Welcome you, sir.
Thank you, ma'am.
Thank you, sir. Over to you.
Thank you.
Thank you very much.
Very good, interactive, and crisp panel, because Dr. Pratik and Dr. Aarti are there, and we have excellent panelists today with us.
So thank you very much, Dr. Kiranmai, Dr. Krishna Kumari, the entire FOGSI team behind this excellent program for inviting Dr. Aarti and myself to conduct this panel. Welcome to our experts and our panelists. We are already 1 hour behind schedule, so I'll keep it brief before I hand over to Dr. Aarti. We're going to discuss 4 common clinical case scenarios. Questions are going to be precise and to the point. I hope the answers also will be. Please unmute yourself before you speak. Raise your hand if you wish to contribute. Don't interrupt the other speakers. That would be preferred. Evidence-based replies are always appreciated, especially this is a FOGSI platform, and we'll try to restrict ourselves to 10 minutes per case. For the first case, I hand over to my co-moderator, Dr. Aarti.
Thank you. Thank you, Dr. Pratik. I would like to congratulate Dr. Krishna Kumari and Dr. Kiranmai for organizing this wonderful conference. And without wasting any time, we'll move on to case-based scenarios, because all the evidence-based fact we have already discussed in the earlier talks. So my first case is a 13.5 years old girl with her age of menarche at 11 years and BMI of 29. She is presenting with prolonged interval between cycles of up to 8 weeks and heavy losses during the periods. The mother has got an ultrasound report which says that the findings are suggestive of PCO morphology. And the mother and daughter both are really concerned that they have developed PCOD and her entire reproductive career is going to be affected. So how will we counsel her and will plan her investigations? May I invite Dr. Vidhu to suggest that how should we proceed with this young girl? Dr. Vidhu, can we see you? Otherwise, any of the panelists,
Yes,
Dr.
Dr. Mahesh here.
Yeah.
Hello.
This is
Hi.
because she's just an young girl, and just a couple of years back she has been having menses.
Oh.
It will not be prudent to call her as a PCOD as of now so soon. I think just by ultrasound criteria, that too, what we'll be doing is an abdominal this lady. So even these the cycles of up to 8 weeks could be even physiological. I mean, they don't have to be because of PCOS, even because just onset of menarche, it could be physiological. So I think we need to wait before we call her like that, and before that we need to rule out the other reasons for the such a this problem. Otherwise, I don't think we should call her PCOD so soon.
So what will be the basic investigations which we would like to offer her? Because if we'll tell her this is just a physiological change, she will not get convinced and she'll definitely go to another clinician. So what other tests can we do just to confirm that she's not having any hormonal problem?
Hi, Dr. Aarti. Can I answer that?
Hi. Yeah, sure.
Yeah. So thank you, FOGSI and the team for giving me an opportunity, and looking forward to see you all for the Yuva conference.
Sure.
And she's a young girl, and she had a menarche at 11 years, and her BMI is high. and she has interval cycles up to prolonged cycles up to 8 weeks. So we must, the ultrasound is suggestive of PCO, but we should recommend the basic on her profile, CBC and routine tests. Plus, we should have a routine hormonal profile for her, FSH, LH, and because she's a PCOD, and she's not hirsutism, right?
No, she doesn't have facial hair. In
Right.
fact,
So
we are not calling her a PCOD also because she's
Yeah,
just
but-
13.5 years old.
Yes,
They're
we're
just
not-
suspecting that someone has given her the doubt.
We would just like to do her basic hormonal profile and a routine test, and we would just like to, she should take care of her weight, her diet, her exercise, which might let her to be into regular cycles, and we can add to her little vitamins and vitamin D also as a supplementation and exercise. Sometimes these measures can help her out, and she might feel good also.
Yeah, thank you. So, as we all have seen the PCOS defining criteria by Rotterdam and National Institute of Health, can we change the slide, Dr. Pratik, or I can share screen and
That's okay. You can just tell me when to advance. I'll go.
Yeah. Okay. So this we have already seen that for National Institute of Health, there should be 2 criteria without ultrasound. And in Rotterdam criteria, there has to be 1 biochemical sign along with irregular cycles and PCO morphology on ultrasound. But for adolescent PCOS, the ultrasound morphology is not taken as one of the criteria. So basically, we have to go by the irregular menstruation and signs of hyperandrogenism. We can go to the next slide. May I ask our experts like Dr. Achla, she's in a busy hospital, that ma'am, how many percentage of young girls are you seeing nowadays in your OPD who are coming with PCO-like symptoms?
You see, the PCO-like symptoms, there are many, and they all come with Google diagnosis of PCOS. But actual PCOS is not so common as we would take it by the ultrasound. They come like a girl like this with periods problem and ultrasound diagnosis, there are many. But actual PCOS are not so many. I would not be able to give you exact percentage, but definitely 1 out of 10 who are diagnosed as PCOS are not PCOS.
Yeah, so the incidence may vary between 5 to 16%, depending upon the ethnicity.
Patwan tayari? तो जैक फर्स्ट opinion peristalsis આવી ગયા તો સિપ્સ આપી દો
Can we have?
Yeah, can you mute Dr. Shefali? I think.
Dr. Aarti, your audio is not coming through.
We can have, he had unmuted me. He had muted me now. So we can go to the next slide, Dr. Tambu. I would like to bring everyone's notice to the latest Barcelona PCOS guidelines in 2018 ESHRE meeting. And these guidelines are formed in association with Center for Research Excellence in PCOS, along with ESHRE, ASRM, and other professional societies on the evidence-based to clarify that these guidelines are aimed to facilitate timely and appropriate diagnosis for women with PCOS whilst avoiding overdiagnosis, especially in adolescents. Like this case, she was unnecessarily being labeled as PCOS on the basis of ultrasound. So specific recommendations which include are that ultrasound is now not recommended in diagnosis in those within 8 years of menarche. And rather than diagnosing them as PCOS, we should separate this group of young adolescents as at-risk group, and we can identify them and where the diagnosis is not sure, but we can motivate them to change their lifestyle, to take care of their weight and physical activity so that they don't land up into a classic PCOS when they grow up. We can have the next slide quickly. So these grade of recommendations all of us, we have been seeing in the previous lectures. We can have the next slide. This one, if anyone would like to explain, because the criteria of irregular cycles amongst adolescents is also different, because a lot of times these girls, they are overweight and they just think that their periods are irregular and they think that they are having PCOS. Would anyone like to describe the quality and grade of criteria for irregular cycles, which labels them as PCOS?
Actually, this has been twice explained in the previous lecture.
Okay, then we can go to the
Do it
next
again.
slide, ma'am. Yeah, we can go to the next slide, and which says that for hyperandrogenism also, there has to be acne, alopecia, and hirsutism. And we have to understand the negative psychosocial impact, which Dr. Pratik is going to discuss in detail. And regarding the Ferriman-Galvez score, we have discussed. We can go to the next slide, please. Now, this is important, the ultrasound criteria, although we have discussed it, but in adolescents, because we are doing only abdominal ultrasound, so we have to mention the volume and not the follicle size, which cannot be seen clearly except in very thin girls. So if we are doing transabdominal, these details, once they have been discussed, that the follicular count has to be more than 18 to 20 rather than 10 per ovary to label the ovaries as PCOS. We can go to the next slide. I need the opinion of my experts regarding AMH levels. Quickly, are we getting it done for young girls?
No, we are not getting it done
We are
for
not
young
doing
girls.
Yeah, AMH level are not recommended as a part of diagnosis of PCOS, especially in adolescents. You're only using it when you have a patient of infertility. The relevance is there only.
That's what the message we want to give to the audience. Next slide, please.
That AMH should not be done for diagnostic purpose as of now, because we don't have enough evidence for its use. Definitely it is increased and it can be a surrogate marker, but as of now we are not using it for diagnosis. But in infertility patients, yes, AMH has to be done when we are treating infertility.
Yeah, thank you. So this criteria of irregular cycles beyond 2 years of menarche should also be kept in mind when we see these young girls, and the criteria for 8 years post menarche for defining them as PCOS with irregular cycles should be kept in mind. We can go to the next slide. I think that will be the last slide. Pathophysiology we have already discussed, and the test, maybe Dr. Dinesh can quickly tell us the test, because if the girl has hyperandrogenism signs, then we have to go for testosterone levels and 17-hydroxyprogesterone levels.
Yeah. So first we have to do assays to confirm that the girl is suffering from PCOS. We have to find the evidence of hyperandrogenism by means of test like serum total testosterone level, oral glucose tolerance test, and it should be done along with the insulin level, because fasting glucose sugar is not, and insulin level is not so sensitive. So we have to do 2-hour postprandial sugar and insulin level to be more specific and to diagnose as a case of insulin resistance. And we can go for serum hydroxyprogesterone level to assess that it is not the high testosterone, not due to other causes like non-classical adrenal hyperplasia. And serum thyroid level is very much important, thyroid profile, so that we can rule out the thyroid abnormality which may lead to menorrhagia or other menstrual abnormalities. And the prolactin level also is important, because prolactin level and thyroid level, these are controlled by the TRH, which regulate the both hormone. Thyroid and prolactin level can increase if a higher level is increased.
Yeah, thank you. Dr. Pratik, we can skip the next slide and go to the, this one I wanted.
Can I make a comment here?
Sure, Dr. Achla.
I think we are not doing total testosterone level. We are doing androgen index, because total testosterone are little, they may not be a good indicator, because they maybe increase with the high level of serum hormone binding globulin, the free testosterone will be less. So we are doing androgen index at our institute, not just total testosterone.
Yes. So for this young girl, there is no excuse for delaying the diagnosis, but at the same time, we should not overdiagnose adolescent PCOS. Thank you. And I'll invite Dr. Prateek to
Can I
go to the
summarize?
second case.
Can I summarize your this thing, Aarti?
Sure, ma'am. Sure, ma'am.
Basically, in young adolescent, whenever we are looking at the adolescents who are like, in your case, it is 13 years of age, and here her menarche has occurred only 2 years before. So labeling her as PCOS we cannot do according to the criteria. And the second thing is ultrasound also we cannot do it. Normal ultrasound, okay, fine, we need to do it, we do it. It is not for the labeling of the PCOS or anything of that sort. And here, if the patient is having irregular cycles, we need to check for her blood profiles, whether the patient is having any other hemolytic disorders or what, because of which she is bleeding heavily. And her detailed history needs to be taken into account also. And if we have to label her, we need to wait for 8 more years, that is not before 20 years, roughly around 18 to 20 years of age of the patient. We don't label those adolescents as PCOS per se.
Yeah. Yeah. Thank you for summarizing it and giving us very clear tips. Thank you, Dr. Aarti.
Yeah, I would like to add one more thing, that in taking the history, we should know whether the girl is taking any hormone therapy. Like I have a patient who had a growth hormone deficiency and she is on growth hormone. And because of that, she has presented with menstrual abnormality and like PCOS-like feature. So it's very important that we rule out those causes also.
Yes, definitely.
While
A
considering
hormonal evaluate, detailed history is important to elicit and come out with it, whether the patient is on any other medication also, which would be causing irregularities in the cycle or anything else in the history, if she's been on any homeopathic medication or any other XYZ medication, that would help us out to understand where she is standing.
Absolutely. We can go to the next case, Dr. Prateek.
Thank you, Dr. Aarti. So this is a 15-year-old girl. She is being teased at school for being obese. Weight is 100 kilos. BMI is 35. She has done the usual lifestyle modification, but she has not been able to lose a significant amount of weight. Her baseline hormonal profile is there on the screen in front of you. Now, this is a very Google-friendly patient and doctor-unfriendly patient. And we get a lot of these currently in our practice, especially if you're in a metro or in a tier 2 city. You'll find that there are a lot of patients who will Google their symptoms and they will think that Dr. Google is smarter than the n number of degrees that you have after your name. So let's cut to the chase. She's read that bariatric surgery is the panacea and this is the solution to all her issues. Dr. Mahesh, you're in Bengaluru. I'm pretty sure you must have come across such a similar case scenario. What is your opinion on this particular issue and how would you convince your patient that this is not to be jumped into straight away?
Yeah, this is a pretty common scenario that mainly the marketing done by those centers for doing bariatric surgery. I think it's a remedy. All ages of patients, they are going to ask this question to you, whether this is a magic treatment for us to lose weight. And definitely we tell them that the suffering after surgery is more than suffering before surgery. So better you don't undergo, and this is never going to be a permanent solution, because even whatever the sleeve gastrectomy, whatever surgery is being done, whatever you lose, first is whatever you lose the weight, along with that you are going to have a lot of nutritional deficiencies and a lot of other symptoms associated, which are really not bearable for you. That is number one. Number two, this is an unhealthy way of losing the weight. And there's no shortcut for this in this way, because even the gastrectomy and whatever you do, you'll again go back to the same thing unless you have a proper lifestyle modification and the controlled your diet and exercise habits. So do we counsel them on these lines, and we try to discourage them from going with such kind of surgeries.
Thank you, Dr. Mahesh. Can I request Dr. Vidhu to take up this discussion and tell us what are the indications for bariatric surgery in an adolescent? Is there any indication at all where you would consider that such a patient should undergo bariatric surgery? Are you there with us? I think Dr. Vidhu stepped out. So let's take Dr. Achla Batra instead, ma'am. Would you like to take this up?
Yeah. bariatric surgery, like very rightly said, it should not be taken very lightly, but there are specific indications when it has to be done. Like in this patient, she has a BMI of 35. But if she had, severe comorbidities, like she had sleep apnea, she has diabetic mellitus, or she has that intracranial hypertension, these patients, they would, if of course they have to be counseled, they have to be given a lifestyle, programmed lifestyle modification, diet and exercise, that also programmed, and even these early start. But in spite of that, if she's not able to reduce weight, then these patients who have, comorbidities, severe comorbidities, they have an indication, and only that vertical sleeve gastric bypass is recommended. And if a girl is BMI more than 40 or equal to 40 and also has minor comorbidities, they also, if they're not able to lose, they are a candidate for bariatric surgery. It has been approved by FDA for that. Besides that, I mean, not for this patient who has not been properly counseled, not been properly taken a programmed diet and exercise, for which very nice recommendations are not there in this 2018 guidelines. There is no.
Thank you, ma'am, for an excellent summary. I think we've lost her audio there. So to quickly go over the evidence as it stands, we need to understand that bariatric surgery is not the holy grail. It's only reserved for patients who have a BMI of more than 35 or 40. And the guideline also currently mentions that this is an experimental procedure. There are various different types of surgery which are available, and we need to keep in mind that we have to have a multidisciplinary approach before we offer bariatric surgery to any patient, leave alone an adolescent. The ethical issues, the difficulties in surgery that will be faced at this age is not something which is up for discussion here. This is not the platform. Having said that, there are certain surgeries like a sleeve gastrectomy, which was mentioned just now, give excellent results long term, and you can get up to 20 to 30% consistent reduction in weight if such surgeries are performed. But they have to be done with proper counseling, and I'm pretty sure that adolescents are not the primary group which we are looking at when we are talking about bariatric surgery. I would just welcome one final comment from our expert. Is Dr. Sampath Kumari ma'am there? Because she's been silent so far, I'd like to involve her here in the discussion. She has herself been the chairperson of the Adolescent Health Committee, and I'm pretty sure she has very strong views on this issue. Yes, ma'am.
Yes, Pratik. Good evening. In the first case itself, I thought since Raki was giving the opinion, I didn't interfere. In the first case itself, it is only an immaturity. There is no necessity to do insulin and AMH in adolescent. In this case, as you have mentioned, the bariatric surgery, proper counseling in the early adolescent. When she is starting increasing the weight itself, the counseling has to be done. Bariatric surgery, as per guidelines, also not advised for adolescent. If no other way, only as a final procedure, you can go with the bariatric surgery, because if she is compelling and she is not able to reduce the weight with the lifestyle modification and she is still 100 kg means no other way, as a last resort only we have to go for bariatric surgery. As far as adolescent is concerned, diet and exercise should be started from the earliest stage.
Thank you, ma'am. Thank you so much for your kind words. Dr. Kiranmai ma'am, do we have time to do one more case?
Yes, Dr. Pratik, 5 minutes.
All right. Then I'll hand over back to Dr. Aarti to take us through the last
Thank you
case.
so much.
Ma'am, you will need to unmute, please.
This 18 years old first year MBBS student, she comes to us with complaints of cessation of menses for past 4 months. She's not indulging in any sexual activity and for past 3 years. At the same time, she complains of excessive facial hair and activities in her mother too. And on examination, her weight is 74 kgs, her height is 160 centimeters with BMI of 29.9, and her Feynman-Galvez score is 12, and she has grade 2 acne, and she is really concerned about her looks, being in a co-ed college, and she is desperate to get rid of all her problems. So how do we help her? Dr. Achla ma'am can, or Dr. Would you like to suggest what should be the minimal therapy offered to her? And
the classical patient who needs, the full works of PCOS, because she has amenorrhea for 4 months. So that is more than 90 days of amenorrhea is there, and she has acne, facial hair. So she is fitting into the criteria of PCOS very nicely, but her Ferrimin Galvez score is pretty high. So this, besides the usual investigation of the hemogram, TSH, prolactin, and testosterone, we would also like to do 17-hydroxyprogesterone for her also, to rule out some other cause of her hirsutism, because her score is so high. And this girl, first of all, she has to be, after investigation, we have diagnosed her as PCOS, then she needs to have her periods first, and then for that we can give her withdrawal by progesterone.
Yes.
And then after that, she has to be started on oral contraceptive pills. And of course, lifestyle modification has to be given to all patients of PCOS, whether they are thin, whether they are obese, because they help a lot in PCOS. And so many times, after some time, they don't need any drugs also. But initially, this patient has a problem of hirsutism, and so she needs to be given OCPs. And if OCPs don't help her and lifestyle modification don't help her, then we may have to start her on anti-androgens. And for her acne, of course, she'll need treatment from a dermatologist.
Thank you.
And
May I ask,
especially
yes,
her BMI is also high, so she's
Yeah.
also at risk for metabolic syndrome. So we should do a OGTT for her to see, and also we should do a baseline lipid profile, because she is a candidate who can have metabolic problems, especially with the history of diabetes in mother and high BMI.
Thank you. Dr. Dinesh, for how long would you like to keep her on oral contraceptive pills to have improvement in her hirsutism levels?
It should be at least for the 6 months before we can find any change in her facial hair growth, because the growth of hair is continuously taking place. So it needs to be suppressed, the hormone needs to be suppressed, so that the hair growth which has already started will grow. But those who are not started yet will be stopped. So, and this process will take at least 6 months. So at least 6 months should be there to find any changes.
And your choice of FOGSI pill, because she's overweight, she's not willing to...
Low dose oral contraceptive pill. And it will be better if we can have some anti-androgen drugs in it.
Yes. May I ask Dr. Achla, please, about her views on low-dose estrogen pill and its effect on her androgen levels? Because there are a lot of studies which say that if the estrogen content is good, like if you use 35 microgram estrogen with anti-androgen progesterone like cyproterone acetate, the circulating levels of sex hormone binding globulins, they increase, and then they reduce androgen levels. So that bias has to be cleared. The low-dose estrogen pills will not give a very good effect in reducing her androgen levels, but all these pills with cyproterone acetate, if the ethinyl estradiol is 35 microgram, the symptoms of hirsutism, they improve to as good as 60% over a period of an year. Maybe, Dr. Prateek can share that slide.
Agree with you, but lately few guidelines have been coming who are saying that we should not be giving more than 30 micrograms of ethinyl estradiol. And they are also saying that LNG containing pills should not be given. Of course, cyproterone acetate is a good option for androgen sensitivity.
So the pills help by regularizing the cycle, and if she's sexually active, they act as contraceptive. They have good anti-androgenic effects. And if it is low dose and if the girl is working out, there won't be any weight gain. I think now we can have a final comment by Dr. Sampath Kumari ma'am, rather than going in the details.
Thank you.
As the concluding act, Dr. Pratik.
Thank you. It is really a wonderful panel. 3 cases, all definitely needed cases. In the last case, as Achila told, we have to, whatever the OC pills given, we have to give the lifestyle modification. So we
Yes,
have to give cyproterone acetate combination, not only for 6 months, it can be given even for a year. Sometimes most of the girls come back after stopping the tablets. Again, I am not able to get the period. So it is better lifestyle modifications and if needed, even for a year. And another one point I want to tell is before with the combinations of the cyproterone acetate combination, we can ask them to remove the hair, mechanical removal.
Yeah.
Yeah.
So removal of the Please unmute. So removal and then cyproterone acetate combination can be given for 6 months to a year also. In the meantime, lifestyle modification and she should reduce the host. As everyone told, thyroid, prolactin, GTT has to be rolled out. And since she is, if your BMI is very high, other causes of hirsutism, you have to do 17-hydroxyprogesterone. Thank you.
Thank you to our excellent panelists and our experts. And thank you very much, Dr. Kiranmai, Dr. Krishna Kumari, and the entire team. Thank you, Dr. Arati Luthra, my co-moderator, for taking us through those cases. And unfortunately, we've run out of time. One final thank you to all the panelists for being brief and to the point, and we hand over back to the organizers. Dr. Arati, any closing remarks from you?
Thank you, sir.
Thank you,
I
Dr.
think we
Thank you.
missed out on the psychosocial aspect of PCOS, which was very important, but because of want of time, otherwise I think
Yes,
that is one aspect
that was the last case.
should be,
I had kept
it
that
should
at
always
the
be
end.
touched, and it should always, all the PCOS should be screened for this, even if they don't say that
Yes,
they have any problem, they should be screened for it. But anyway, we can't help it.
You can give a
Yes.
statement, Dr. Pratik.
One
You
thing.
can just give a one-line statement direct.
So this is something that we need to bear in mind, that the adolescents are very sensitive to criticism, whether it is body shaming, whether it is being teased, whether it is online criticism, whether it is ragging. And we as clinicians are the first point of contact. We are the ones who would be able to identify it. Sometimes even their own parents wouldn't know. And that is where we have to be sensitive. We have to be aware that these patients are at high suicidal risk, what they call in psychiatrist parlance, and therefore we need to refer them to an appropriate counselor, psychologist, or a psychiatrist as needs be. Timely intervention is important, because if you don't identify it in time, tomorrow you'll read it in the newspapers.
Thank you so much. That was really, really excellent panel and full justice. And apologize for the delay, and we could not do the last case for want of time. Thank you so much.
Thank you for inviting us.
I would like to one more point, madam. I think along with the adolescent, we should counsel the parents also, so that
Yes.
they take care of the diet properly. Because nowadays we are very fond of giving our children here, go and get a McDonald's burger, pizza, and all these things. So we should counsel the parents also to promote healthy diet in the children's.
That brings us to the end of this wonderful panel. We are going to the last but a very important session added by Krishna madam, because this she felt should be part of all our CMEs, the article review, scientific article review. And for this, I invite none other than our editor of Jogi, who better than her to start this series with, Dr. Geeta Balsarkar ma'am. Can I have Madam CV, please? The topic is, can you go back to the previous slide? Gut microbiome in PCOS, and we have Dr. Geeta Balsarkar, who is the editor-in-chief, Journal of Obstetrics and Gynecology of India. She is professor, unit chief in Nauroji Wadia Maternity Hospital, St. GS Medical College, Mumbai, and librarian of MOGS and president of Mumbai Menopause Society, chairperson Young Talent Promotion Committee in FOGSI 2013 to 16. Welcome you, ma'am, to moderate this session and to present this paper review. We have Dr. Ruchika Garg, who is young and known for her scientific pursuits. Dr. Ruchika is, though young, is already a professor at Department OB-GYN, SN Medical College, Agra, India. She's a joint editor of SAFOG and does a lot of work in this. Editorial board member on Journal Midlife Health, JK Science, Secretary of Indian Menopause Society, Agra, 2018.
Okay, thank you, Dr. Kiranmai, for the wonderful introduction.
Short of time. Yeah, please do go ahead. Geeta ma'am, do we have you? Yes, ma'am.
Yeah. What I wanted to say was, like, I raised my hand because I wanted to tell something regarding what Pratik was saying, that I had a 17-year-old girl. Since I work with the Vadia group of hospitals, this girl was doing this Bombay dyeing. Those days we used to have models who used to come with, they used to be, I don't know, Film Fair and Bombay Dyeing used to have all these models. So we used to get 17 and 18-year-old girls who came and said, see, I have gained weight here. Look, I have gained weight here. And then the next thing I heard was, you give her some tablet, you do some counseling and you send her, and she hanged herself the same night. So this is what we need to understand, like exactly what Pratik was saying, that in any other patient, maybe you have little time, you can counsel or call her with a relative a day back and then again or something. In case of an adolescent, you just don't have time. Whenever they come to you, you have to act immediately with psychological problems. Otherwise, they take drastic steps. They are known to take drastic steps. This was a point I wanted to make.
Thank you, ma'am. Dr. Ruchika, please.
Yeah, just a minute.
Okay, we all talk about this gut feeling, my gut feeling is that this will work, or my gut feeling is that this won't work. How do you think this terminology came? Because
ma'am, you're muted. Unmute yourself.
In the gut is very, very important, which has been passed on generations to us. A lot of South Indians, we don't feel our meal is complete without taking, the dahi bath or the dahi, or what is it actually? These are all modifications of the gut microbes. So Ruchika is here to tell us gut microbes, and since the topic we are talking today is on PCOS, she's going to talk about gut microbe and PCOS, and what we as clinicians, how we can change our practice to help our adolescent and PCOS with their gut microbes.
Thank you, Geeta madam. So let us proceed. So there's an ancient Hippocratic saying that let food be the medicine and medicine be the food. So this still holds true, as I was seeing in the last panel discussion, as discussed by Dr. Dinesh Pathak also, that we should make our adolescents more of gut friendly by avoiding fast food. So what is the history of how did we started with this? In 2012, there was a dogma hypothesis was proposed, where it was proposed that when there is an imbalance of the intestinal flora, there is a release of lipopolysaccharides into the systemic circulation. And these lipopolysaccharides, they are endotoxins and they increase the intestinal permeability. So the mucosal barrier of the intestine is lost, and these just trigger the inflammatory response and the immune response. These lipopolysaccharides, when they enter into the circulation, and the macrophages of the patients with dysbiosis of gut microbiota, they are just sitting on the fire point. They are just ready to release the inflammatory reaction as soon as they encounter these endotoxins, and this leads to insulin resistance. So even the brain gut peptide secretion is also altered, and this leads to dysbiosis leads to altered isolates B cell proliferation, leading to fat accumulation, leading to insulin resistance and compensatory hyperinsulinemia. Even the GI hormones like ghrelin, it's a good hormone and peptide, YY, they show a negative correlation with insulin resistance and BMI. So basically, obesity and high carbohydrate, simple sugars in diet, and high fat and low dietary fiber rich diet. It causes an imbalance of the intestinal microflora and increasing the gut, and this leaky gut predisposed to all the variety of things. And some good bacterial species are lower in PCOS patients, and some other bad bacteria like bacteroids or E. coli, Escherichia, different species are increased in patients with PCOS. So this dysbiosis of gut microbiota, it affects all the levels. It affects at the level of small chain fatty acids. It affects the choline metabolism and leading bile acid metabolism, then intestinal permeability, even the brain gut axis. This is the reason that patients with PCOS are more prone for developing anxiety disorders and sleep disorders, because by the neural pathways, the brain gut axis is altered and they have low serotonin levels, and the vagus nerve is stimulated, leading to more parasympathetic influence. So I am discussing one study, and it's an Indian study. This is the only Indian study where gut microbiome in PCOS patients were studied in Kashmiri women. It was done by Hassan, and this Department of Microbiology Kashmir, Pondicherry, and the Department of Endocrinology Jammu Kashmir, along with this London, UK, there was a section of genomic of common diseases. And this was published in 2017 in this journal. And the background is that in rats, when the prenatal exposure of high androgen levels is there from mothers with PCOS, there was dysbiosis was found and cardiometabolic functions were altered. So it is hypothesized that the diet may induce bacterial dysbiosis. And it has been found that with fecus have been transplanted from rats who are mice who are having PCOS into mice who are healthy. Then they leads to decreased fertility, and they were more obese, and insulin resistance was found more in this, and vice versa was also true when fecal transplantation was done. So here the material method is they actually they took the PCOS patients, and it's more of a biotechnology and microbiology and pathology study. So they profiled the microbiome in DNA isolated from fecal samples in patients with or without PCOS. And then they assigned genera also. And then they compared the relative abundance of different microbial species in the both patients. They took 20 women with PCOS and 20 control women. And the duration was in 2017. And the cases, they were qualified by Rotterdam's criteria, PCOS, and controls, they had no PCOS. And those women who were excluded were those who were taking antibiotic or who were on OCPs, those who were taking anti-epileptics or certain bigonides or insulin sensitizers, or patients on proton pump inhibitors, or those who had a previous history of diabetes or coronary artery disease. Likewise, as Dr. Abha said, that we have to exclude congenital adrenal hyperplasia, and hyperprolactinemia and thyroid cases were excluded. And those patients who had a GI disease or appendicectomy were also excluded from the studies. And they were all this TSH, prolactin, and FSH-LH hormonal profile was done, along with fresh stool sample were collected within the same week when the blood was collected, and the samples were collected in the morning, and they were stored at ambient temperature, and they were further processed within the next 60 days. And we can see that the height, weight, BMI, waist circumference, waist hip ratio, they were more in cases with PCOS compared to the controls. This is cases and this is controls. LH-FSH ratio, testosterone, likewise prolactin was high in patients with PCOS. And the patients were adjusted for the stool sample according to the day of the menstrual cycle at stool collection, and the stool consistency was also adjusted. They have given different parameters for the stool, whether they had watery stool, solid, clumpy stool, and in microbiology, biotechnological levels also they did adjustment for the patient so that to avoid the confounding factors. So these were the results. There was statistically significant difference between the PCOS cases and controls. And when this multivariate model and Mann-Whitney test was applied, and p-value less than 0.05 was considered as significant. As you can see, these are the cases and these are the controls. So there is a different bifidobacterium is higher in cases of PCOS patients. Likewise, Megaspora, Sarcina, the different species, they are altered. Some are more, some are less. So there was, as you can see, Sarcina, it was more, bifidobacterium was more, and when they were adjusted for BMI, lactobacillus did not reach the corrected level of significance. And these were all increased in gut microbiome in PCOS patients. And it was found that the patients with those who had Collinsella and Paravira, they had higher fasting blood glucose levels, and they had larger waist tape ratios. And this study was the first to report the association of these bacteria in relation to PCOS. Now we are doing the review of the study. Let's see the limitation of the study. The sample size was very less, but they say that the sample size is comparable to other pilot studies in the field. And to deal with the sample size, they use non-parametric test. And although this does not allow to account for covariates, the association with different species turned out to be robust and confirmed by both statistical methods. And one biotechnological point was there, that they lacked a lack of resolution. For that, they by shotgun metagenomic sequencing, which could be avoided. And what the other literature says in relation to this, and they found that bacteroids, Escherichia, Shigella, these are villain. Streptococcus, these are not good bacteria for the PCOS patients. And these were inversely correlated with ghrelin. And they were positively correlated with those patients who had more hyperandrogenemia. This was a Chinese study. They had more levels of bacteroids, Shigella, and likewise other also. And they found there are many 2-3 studies. They found that gut microbiota are associated with obesity and metabolic syndrome. And in relation to diabetes mellitus also, now gut is to be studied. So, but there is a hitch that but we cannot conclude from these studies whether this is a cause or a consequence of metabolic disturbance seen in PCOS, or if it's specific to the Indian women. So these findings, but anyhow, strengthen the role of gut microbiome in PCOS and warrant further powered research. This is another study and from Finland, and you can see from the conclusion, but they found that PCOS and non-PCOS women did not suffer with similar BMI. When the BMI was adjusted, they did not significantly differ in their gut microbial profile. But according to the metabolic health, there was a significant microbial changes in the PCOS individuals. Even the vaginal microbiome in PCOS patients are altered. In a study published in 2020 in Clinical Endocrinology, it was said that lactobacillus was lower in PCOS women, this species crispatus, whereas mycoplasma and prevotella were higher in PCOS patients. So in another study, it was found that when the mice were fed with inulin and metformin, there was an improvement of PCOS. And it was found that their lactobacillus increased, their bifidobacterium increased. And even bile acid metabolism has been linked with PCOS. So when the patients were administered interleukin 12 and glycodeoxycholic acid, improved insulin resistance was found in patients with PCOS. Now, what we have to learn from these studies, that high fat diet, it increases basically bacteroids and it causes less of good bacteria like lactobacillus and others. And when simple sugars, carbohydrates are there more, that is if the patient takes more of sugary foods, then the good bacteria are reduced, whereas those patients who were taking whole grain and wheat bran, so they had an increase of good bacteria in their gut. So what are the clinical implications for this practice in future? Fast food culture can cause dysbiosis, and in future, supplementation with prebiotics, probiotics, and symbiotics in the women might improve many biochemical findings and may benefit PCOS patients. So, in the light of this evidence, it is possible to believe that a future therapeutic approach for PCOS may involve gut microbiota. We are reading all this because we have to find a therapeutic approach for PCOS. So thank you all.
Very well presented papers, and actually very good take home message. Now, a lot of research are happening in gut microbiota, in not only in PCOS, even in IUGR, in preterm, even in pregnant patients. We are discussing a lot of gut microbiome, and they say that this leaky gut could be leading to gestational diabetes and other problems, and even IUGR for that matter. Just 2 days before, we had a meeting with our neonatologist where they were asking us if we can supplement the mothers in IUGR patients with probiotics so that they can have better outcome for the IUGR babies after delivery. Because a mother's probiotic, it colonizes the vagina and then it helps prevent infection in the IUGR babies. So a lot of studies are happening on gut microbiomes nowadays. And like, sure enough, we all knew estrogen has an effect on the gallbladder stones. We knew fat fertile female 40, so they have a higher chance of gallbladder stones. But what exactly was the pathway, we didn't realize. Maybe it is through alteration of the gut microbiomes. So we must know that in PCOS patient, there is a high estrogen levels, there are low progesterone levels, and this could be possibly changing the gut microbiomes and causing leaky gut, which predisposes them to diabetes later on. So this is a very good paper and a very good take-home message. Dr. Krishna Kumari, you want to say anything?
Yeah, it was very interesting. That's what I thought, that this has to, having this as a part of our programs, at least will bring in a new culture into our CMEs, that we should be including these papers. And as far as leaky gut is concerned, I agree with you completely. I've been reading about leaky gut even in recurrent pregnancy loss as a causative factor, in preeclampsia. Wherever there's inflammation, I think it's now getting interlinked with the leaky guts. And the role of probiotic, prebiotic is really very, very extensive, and a lot is being coming out. Thank you so much for that wonderful analysis.
Yeah, one point I would like to make is the pharma somehow is pushing a lot of capsules and this, but it is not really needed. There are natural products that has got pre and probiotics as well. And we must definitely encourage patients to use natural products as also.
Right.
Lifestyle modification, that is.
Gut health, I think, should be the next one of the themes of one of the conferences should be gut health in OBGYN. I think we should take it up in that way, and then we can analyze ourselves what it is.
In the first instance, we should focus on the diet itself, less of carbohydrates, less of fat, so and more of probiotics and prebiotics in the diet itself, as said by Geeta madam.
Correct.
And rightly said by you, Dr. Krishna madam, in recurrent pregnancy loss also it says a role. Right. And I couldn't read even about, as told by Dr. Geeta madam, that in IUGR also it has a great role. In diabetes, metabolic syndrome, it's definitely the cause.
Yeah.
I think the more and more we focus on these issues, then comes the full circle that people will automatically go to healthy lifestyles. Otherwise, it becomes like a rote telling that we are going on telling lifestyle changes and nobody is generally practicing.
No, when we are talking about lifestyle changes, we are only putting two major headings. One is have a good diet, do exercise. But exactly when you go into a more scientific way rather than being...
Yeah, when I read this article from that day itself, when lean PCOS girls are coming to us, then we can advise them dietary advice that you don't have to eat outside food and you have to keep your gut also healthy. Because many times it's very difficult to make the patients understand that what is the cause of this lean PCOS.
Yes.
Yeah.
True. Dr. Krishna Kumari, our next edition of the journal is coming out in March, April, and it is a very focused topic and weight loss in women.
That is the topic of the next the journal which is coming, and all the articles there, right from editorial to case reports, are pertaining to weight loss in PCOS, in adolescent women, in pregnancy, postpartum, and menopause. All of them are touched.
And I remember
So
you were
that
a
is the
part of that AIMS DST program also for as far as young people, girls are concerned. Weight
So
loss.
I'm going to write an editorial with the guidelines or regarding weight loss and what amount, like whatever we discussed in that particular this, along with Dr. Piyush Ranjan in AIMS, that is going to be there in the guidelines. So the March-April issue is entirely focused on theme. Theme is weight loss in women.
Very good. I
That's
think we
wonderful,
should
ma'am.
become more focused in our
Approach.
very good. Jogi is also going the right way, I think.
Ma'am, Geeta ma'am, we would like to tell you in our next Quest-2 series on PPH, again another article review on the role of tranexamic acid in PPH. That is what I think every Quest series will have an article review and discussion. I think it was really good, Ruchika.
No problem.
Thank you, Dr. Kiranmay. Thank you, Geeta madam, for your pearls of wisdom.
Thank you, Dr.
And thank,
Ruchika.
and thank you, Krishna madam, for bringing this topic. I mean, bringing this
It was,
article review, which is required because our then
I think
others will be
very
more
well.
focused on
Keeping
research.
entirely separate, I think that mixing of.
I think all webinars should have, one review. Just takes 10 minutes, 12 minutes of time, but it's really good.
It is must. Thank you, ma'am.
Thank you so much. I think you are
the recording of today is much needed because I also could not focus on all the this thing, and I hope we will be given the YouTube recording entirely on PCOS. So it will be much useful. FOGSI sir, are you there? Can you give us closing
The link
remarks?
is already there. It's there in your that group. There's a link in which you can.
Ma'am, that YouTube link. They have put
it is there. In that you can see.
I see FOGSI sir, but it is muted. I think he was there till the end, patiently from the beginning. He has been the vice president in charge for this program, guiding us throughout. Thank you, sir. I thank first Shanta madam, President FOGSI, Madhuri madam, and the entire team of FOGSI. All the vice presidents were all very encouraging and give lot of freedom to us in framing the entire program. And all the office bearers, Dr. Suvarna Khadilkar madam, Dr. Parikshita and Dr. Niranjan, and our own Dr. Aruna, and Dr. Krishna Kumari madam, who is there always. No worries when she's there, as long as I mean, regarding the scientific program content and all. And this article review really has come out well. Thank you, madam, for that. And I thank all our esteemed speakers. Suvarna madam's talk was very extensive, though it overshot time. It was very well, a lot of research and
the whole program.
The tone for today's CME, then Dr. Abha, and then we had the 6 fast track 6 topics also has come out well, I think, though it was really 10 minutes. And the panel, thank you, Dr. Pratik, for taking care of the time limit, and all the panelists and all the chairpersons who have been there for us today. And Tirupati and team, have I missed anyone? Dr.
Guest of honor.
Guests of honor, Dr. Chandravati madam and Usha Sharma madam. They are so humble and down to earth, and there's a lot to learn from them, how they answer back and how they keep in touch and how they tell even 10 minutes delay also if they're going to be late or anything, and the patience that they show. Really thankful for them to have joined us. Always a blessing. And Dr. Nandita madam, who was the expert of experts, but unfortunately madam had to leave little early. And Dr. Sampath madam, Dr. Mandakini, and Dr. Raki, who had joined us impromptu to give us her expert comments and also as a panelist. Did I forget anyone else, ma'am?
The panelists.
Yeah, the panelists, all of them. Achla madam, then Dr. Mahesh and Dr. Dinesh, and then we have had Dr. Vidhu, and 2 or 3 panelists have dropped because of emergencies. Dr. Bangal sir and all the chairpersons, Dr. Umayal, everyone. Thank you so much. And I again apologize for the delay. We could not prevent it. We'll try for it in the next CME. We have to definitely go on time, Krishna.
And we must thank Kiranmay and Dr. Krishna Kumari for a wonderful PCOS program. I also learned a lot reading about you. PCOS expert now.
Madam, whenever you are there, it's such a value addition.
It's an added.
Yes, Krishna Kumari and Kiranmay, wonderful.
Thank you, ma'am. Sampath.
Thank you, Sampath.
Thanks for joining.
Nice, nice that you have joined us. It's nice.
Yes, I was there from starting, from inauguration
Yeah,
time.
and you can't help yourself whenever